Hi guys, hope you're doing great and you could revise the questions that we had discussed yesterday. And today is another day, so you get another shot at attempting all these questions. The objective of these sessions are to fine tune your reflexes so that you are able to answer in the shortest possible time frame. And you will also have to, try and save some time in some of these questions so that you can invest in your time in those questions where the options would be relatively longer. So the audio, the visual part is perfectly fine, I think, and people have joined in. So thank you so much, guys. Let's get started. And yeah, before I start with this question, if you watch this movie, Apocalypto, this is a very interesting movie. And like the highlight here is what I want to bring to your attention is that they're shooting an arrow, and that arrow is tipped with a poison. And that poison is the one which is basically given in this question. So let's get started with this. The question says hypotension, and then along with hypotension, there is hypothermia and hippus as well. What you mean by hippus is that there will be an alternative constriction and dilation of the pupil. So there is an autonomic instability present in this patient. The main poison that we are talking about in this particular case, where these H's are present, there's an autonomic instability. So there's a hypotension, there's a hypothermia, and there is a hippus as well. Meaning of the word hippus, I'll say again, is alternative dilation of the pupil followed by constriction of the pupil, and this is happening alternatively, it's like the pupil is becoming bigger smaller alternatively. That's because that sympathomimetic stimulation causes mydriasis, and then parasympathomimetic causes meiosis. So because of this particular fact, the poison that we're talking about is that is aconite. That is one of the main aspects that you need to remember for this one. The roots are the most poisons. Exactly, Adi, you are right. And yesterday we discussed regarding the dancing eyes and dancing feet. That is opsoclonus, myoclonus. That is a feature that is seen with neuroblastoma. But today I'm talking about yes. That's the last session that you would have with me, and you would be through to the other side, so you would not need any of this nonsense. Okay, so the answer for this is option number A. As far as cerebra tibitia is concerned, that is option number B. This is also called as yellow oleander, and the main problem with this would be that they will act like the poison from this particular plant will act like digoxin. So it will contribute to digoxin toxicity in a patient, and that would be one of the main issues. One of the poisons which is present here, because toxicology is something that we tend to neglect a bit, so I put up questions for the same. And one of the toxins which is present here is this thivation A and thivation B, and as I said, this is gonna act like a cardiac glycoside, and this cardiac glycoside will then contribute to development of ventricular bigeminy and ventricular tachycardia, and those are one of the common poisons that can be seen. Then as far as option number C is concerned, capsaicum, that is used in preparation of that pepper spray, no? That is like it will be irritating to the eyes of the patient. Capsaicum, as you understand, would be basically chili. So that's used in manufacture of chili spray. And then Calotropis gigantea is the one that I've shown here. It's called in Hindi as mother also, and MADR, mother. And this will also be contributing to cardiac toxicity. It will behave like cardiac glycosides. So the end result of both option number A and option number D, they are going to be affecting the heart. Option number B and option number D. Option number B and option number D will be affecting the heart of the patient, and our patient was initially having an autonomic storm. So the answer here will be option number A. And you guys are anyway good with this, so I had good answers also here. Okay, yeah, homicidal agent, exactly. That is what I'm saying. That if you watch this movie, Apocalypto, you'll notice that they're using those poison arrows, poison aconite root in the poison to kill the opponents. Okay. Alam, don't worry. I think this is just a temporary phase, and you'll gradually come over it. And it's my job to actually address as many queries as I can in possibility. So I know it breaks the continuation, but yes, I think that is also important. Okay, so moving to the next one, he says, which of the following is not correct about a scorpion sting? And scorpion sting would again contribute to a persistent depolarization of the sodium channels. So there's an autonomic storm. We use prazosin for it, understandable. And tapping over the area of the sting will increase the pain and the paresthesias component. So this makes sense. But then it does not cause sodium channels to close. The wrong thing here is it is written sodium channels to close. It is like a persistent depolarization that is happening. So the answer for this would be given as option number B. Good. I think you are hitting the comment buttons right, and you are coming to the correct answers. And I hope that you are not using the app as a prop here. It is that you are gonna be focusing more on like the aspects which are being relayed on the screen at the moment. So Moving to the third one for today, this is a 20-minute whole blood clotting test. I think I can't make it easier than that. The guy has had a viper bite, and there is like gonna be extensive bleeding that could be present in a patient, extensive bruising that can be present. So we simply take the blood sample of the patient and keep it in a tube. And normally, if you keep a blood tube for like a couple of minutes, the blood is gonna clot. But in this case, even after inverting the tube, you can see that the blood is literally liquid. It's like a friable clot, or the clot is like literally like liquid. That's because of the afibrinogenemia that is caused by the viper bite. So the answer in this particular case would be a venom-based afibrinogenemia. And what I've also shown on the right hand side is the neurotoxicity. This could be a cobra or a crate bite that can result in neurotoxicity, and thereby there would be like paralysis. The patient will have difficulty in breathing. There will be difficulty in talking. And one of the important tests that we use in a patient who had a cobra bite will be a single breath count. Like we'll ask him to do counting like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Like you and me can say that fast, but a guy who's having a diaphragmatic paralysis will not be able to do that. And we anyway need to give anti-snake venom to be given in these patients. I mean, the standard part is ASV, and the dose of anti-snake venom, that is 10 to 20 vials, is same for both children as well as for adults. The logic behind that is simply that the amount of poison that will go in the body of a child will be equal to the amount of poison that will go in the child of an adult. So that 10 to 20 vials that we're talking about would be a universal one that would be used in the patient. Yeah, what I wanted to say was that that look upward gaze and that eye thing may not be so reliable because patient is scared, so he may not be able to follow your commands. But then that diaphragmatic weakness assessment is of paramount importance. That's why, like I said, a single breath count would be important. Yes, not important for humped viper. Yeah, that's one of the parts that I have highlighted in the video for anti-snake venom. That is snake bite. So do check out the emergency medicine component and have a look at those questions related to emergency medicine that are shown in the current version. That would help you much better. And then, yeah, one more point I want to say is yesterday, I hope you would have gone through the various classes of COPD because there were a lot of queries that were coming in for that COPD based question. So this is what I was saying. I thought I should include an image in this, that is group A, B, and E. And that is why yesterday, like in the case that we were discussing, the case was fitting into group A of category. And that is why the treatment for this patient was indacaterol. That is like a once a day bronchodilator that would be acting for 24 hours. So I thought I should just bring this to your notice. Okay. Now, moving to the next question, this was a good one. I mean, venom-induced afibrinogenemia is what we are talking about for this one. That is 103. We move to the next one. Paraphilia by the name of Pygmalionism. This can be ruled out by exclusion only. Sexual arousal and giving pain, that would be like sadism. Then is gonna be voyeurism, others indulging in sexual activity. So, I mean, if you just go into the exclusion part, this would be pretty easy to rule out. And then is scatophilia, that is excreta. So falling in love with a toy, like you would have seen that, those people will buy those dolls and stuff like that. So falling in love with a toy is Pygmalionism, or falling in love with a statue. I mean, it could be a toy, it can be a statue, it could be some kind of an object with which the person is getting a fetish for. So the answer for this is option number D. Great. Next is a lung specimen on which you can see hemorrhages on the surface of the lung. That makes it easier to solve because you see we get like a lot of, I would say, petechial hemorrhages with respect to strangulation and hypoxia. But because he's talking about lungs, so what we're talking about in this case is Pultov hemorrhages. And Pultov hemorrhages would be seen with respect to lung drowning. That would be wet drowning that I'm describing at the moment. The answer for this would be option number B. And a miscellaneous question for you is what is the cause of death in hydrofusion? While I'm describing this hydrofusion and I expect your answers, I'll just describe a video that went viral about December last year. The couple of guys at Rishikesh and they are jumping into cold water. So like one guy is jumping into cold water of the river, and meanwhile he's asking his friend to make a video of him to post on Instagram to make these reels. So this guy is like he's an expert swimmer. It is not that he does not know how to swim, and this guy jumps into that cold water of the river and he never comes up, because when the face will hit the cold water, then, or if the tummy will hit the cold water, it will cause if I say anything, it will become very clear. Like this guy is, when you jump into cold water, always feet should be going into water first, not the belly and not the face. If face will go into water first, or if for that matter of fact, if belly will hit the water first, cold water, then it will contribute to vagal stimulation. It will contribute to vagal stimulation, and this vagal stimulation can result in development of cardiac arrest in a patient. So even in the movie Titanic, they will show, obviously, I mean, the movie Titanic, they were focusing on Jack and Rose, but in that cold, frigid waters of the Atlantic Ocean, people were jumping into the cold water because there was no rescue coming. So people were dying immediately, and they showed that people somebody jumps into cold water and dies. That's one because of hypothermia. That will take a couple of minutes for somebody to die. Immediately, person lands into cold water, face first or chest first onto the tummy first. Then it is hydrofusion that will contribute to development of cardiac arrest in a patient. And yeah, even rafting, and if somebody is not a good swimmer and person is trying to do adventure sports by watching some Instagram reels, yeah, there can be a possibility of hydrofusion in a patient. That would be cardiac arrest. One more miscellaneous MCQ to you. What is the cause of death in electrocution? Like this guy, he touched a live electrical wire, or like this guy, like recently, but 4 weeks ago, there was a video viral. I think it was Delhi only. Like this guy is wading through knee deep water because after the rainy season, like the water will accumulate in the street, and the electrical cable was dipped in water. Like this guy did not notice that there was electricity in the water, and he went there and he died. So electrocution causes death due to ventricular fibrillation. Exactly. I'm having good answers there. Electrocution would contribute to death due to ventricular fibrillation. Hydrocution would contribute to development of cardiac arrest in an individual. So yep, I mean, those are some of the common things that would be seen. And then you can see those pulse-off hemorrhages that would be seen over the lung with respect to drowning in a patient. Great. Moving to the next one, we are talking about not a component of Waddell's triad. So what is happening in this guy is that this guy is crossing the road and he gets hit by a car. Now this guy is a victim of a hit and a run case. So this particular individual will tend to fall in the bonnet of the car, and then he's gonna be like lifted up and is gonna fall on the ground. So because the guy will take an impact on the leg, so femoral shaft fracture or bumper fracture can occur. He can end up with a hemoperitoneum, more likely, and subsequently a hemothorax as well, but not a ipsilateral. Usually when the person will fall, though he can roll over as well, but most of the time, like, it's a triad only. So in the triad, these three manifestations are present, and not a component is a ipsilateral head injury. And anyway, I mean, a head injury would be with respect to a secondary impact, because when this person will be lifted into air, the car hit him, is lifted into air, and then when he falls, then with the secondary impact you get is a development of a head injury, and that can be usually contralateral, or it can be ipsilateral, or he can roll over, it can be present bilaterally. But in the primary impact that I'm talking about, we would be having is a femoral shaft fracture, and then a hemoperitoneum, and then a hemothorax. So great, I mean, great going at the moment. Then is the case of a motor vehicle accident. It's a deceleration injury, like a high velocity crash that is happening. And in a deceleration injury, what can happen is, one, that there can be a possibility of a whiplash, and the neck will be hyperflex and hyperextension of the neck. So one we can get is a whiplash, and second could be a aortic transection, and that aortic transection is the one that would be responsible for the answer in this question. That would be option number C. So ladder tear, I mean, the tear itself was telling us that some visceral organ is getting affected. So either we were thinking about mesentery or aorta only, because spinal cord will undergo a concussion. Spinal cord will mainly be undergoing a concussion mainly. Because it is well protected inside the vertebra, so it will not be a tear, it would be concussion present. And like the tear is present with respect to the aorta. These are horizontal tears, exactly. Then triad of asphyxial death will include all of the following, except this could be strangulation, it could be throttling in an individual. So every time, like, if somebody is strangulated or somebody is throttled to death, then we'll notice petechial hemorrhages present on the conjunctiva. There would be like a periolar cyanosis present, and there would be extreme amount of congestion, because if the neck is squeezed, there would be a lot of congestion on the face of the individual as well. But abnormal fluidity of the blood would be a component of asphyxial quintet. So there are like total of 5 things present here. So let's quickly revise that. In asphyxial triad, there is bound to be petechial hemorrhages, visceral congestion, and cyanosis. And if you do this, you add 2 more things, that is the fluidity of the blood and dilation of the chambers of the heart, then it becomes an asphyxial quintlet. So because the question is asking about the triad component, which is why the answer in this question will be option number D. Then another question on the throttling part, you guys can quickly comment here. What would be the leading cause of death due to throttling in an individual? Okay, there is an inward compression fracture that will not cause death of a patient. No, like that's a feature that is seen, that there would be a fracture of the hyoid bone. That is understandable. That's not going to contribute to death in a patient. Blocking the jugular vein contributing to low cardiac output. No, that would not be the main reason. I think it has to be related either to the carotid artery or it can be related to the vertebral artery. Throttling causing vertebral ischemia. Vertebral artery is very well protected because it is traveling through the cervical spine. The correct answer in this case would be option number C, because in throttling there is a hypoxia. No, there's a hypoxia induced cardiac arrest in a patient. So every time, like you are dealing with a patient who has died and there's bleeding from the nose. That is one of the very characteristic thing. If there is a bleeding from the nose, the petechial hemorrhages, and obviously you would notice the victim has struggled before the person was strangulated. But then the main important aspect to be remembered is that there is going to be a development of cardiac arrest because of the hypoxia component that is occurring in this patient. No, guys, it is not A. That is a silly mistake. In forensic, you have to get like almost 100% score coming, because that's a very, very scoring subject, I can say. The correct answer in this case would be option number C. And then one more asphyxial death would be hanging. And in hanging, you will always notice like leaf fascia sympathetica. Why do you have this leaf fascia sympathetica, please? Quick answers, please. Splitting of the carotid artery because of the force. No, with throttling, you cannot generate so much of force that there is a splitting of the carotid artery. But if the whole weight of the body is extended onto the carotid artery, so you can have a splitting of the carotid artery. So yeah, it is sympathomimetic stimulation. So the eye on that side, this side पे not लगाया होगा ना, on that side, because of the sympathomimetic stimulation, you will notice the eye on that side will remain open. Like if the person has died, you will notice that on one side the eye is open, and second thing that you'll notice is also that there might be drooling of the saliva from that particular side of the, because the salivary glands are also stimulated, so there might be saliva corning coming from the corner of the mouth of this patient who has died because of the hanging component. Drooling could be present. So yeah, sympathomimetic chain stimulation is the reason behind it, and the death in throttling is due to cardiac arrest. And anytime, I mean, there's going to be a death related to strangulation, bleeding from the nose would always be present. That's mainly because of the all the venous pressure, venous engorgement, and the increase in the venous pressure that would be occurring. The answer to this question is option number C. And then is a question manifestation that would be seen to the sign of the drowning. Yes. Most important external sign of drowning. Okay. So I'm getting multiple answers here. One of the answers that I'm getting is a cadaveric spasm. No, guys, cadaveric spasm may or may not, because cadaveric spasm is a manifestation where if there is some grass in the water, he might be holding, but it may not be necessary. No, that the person might be, there would be grass in the water. It could be running water of the river as well. There may not be any grass present. Washerwoman hands. No, 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 no. I mean, the most important external sign of drowning. I mean, if a dead body is brought by the police and they say, sir, can you just tell us what is the cause of death? And there is no bleeding from the nose occurring, then it is not somebody who was strangulated. Then the next thing you need to notice is if there is froth coming from the nose of the patient. If there is froth coming out of the nose, that means that the patient had drowned and it was the lungs that were getting involved. So the most important external sign of drowning is gonna be lathery froth at the mouth. Important two forensic findings that I mentioned, which you should always pick up, is once a dead body is brought with the police, is if the guy is having bleeding from the nose, or there is like conjunctiva, congestion, and a lot of petechia present, then it is like the guy was strangulated. And if it's going to be frothing from the nose, then it is going to be a manifestation that the lungs of the patient got affected. So the answer for this question is option number A. And I mean, obviously, you're not supposed to comment to the police what is the cause of death, but like you yourself should be knowing, because obviously all those data would be kept in a very recorded format. So let a forensic expert do the talking to the police if required. But what you need to pick up is a characteristic feature. Washerwoman hands is like a feature. Even they can develop in you and me, man. If you keep your hands in water, no. Like if you go to a swimming pool, like recently it was so hot in India, people were spending their time in all these amusement parks where water is present, or in swimming pools. So if you spend your time too much in water, then even your fingertips will start having that washer woman kind of a mottled and irregular appearance. So answer would not be option number D. Yeah, I mean, putting your hands in water for a long time, na, so it can contribute to that irregular appearance of the skin to be present. So it would be lathery froth at the mouth in the patient. Okay. Answer is alpha. Now we have this 55-year-old hypertension patient who's having a tearing chest pain. So mark it. I mean, aortic dissection always comes in a question and always comes in the paper. And we are talking about a live patient now. And the question says that this particular individual is having chest pain in the interscapular area. Every time you're reading chest pain in the anterior part of the chest, it's acute coronary syndrome. But if he says interscapular area, it is aortic dissection, which is to be considered. Now he says CT angiography is done, and then subsequently in a patient, he says what would be the correct management in this particular case. In fact, the current image that is shown is that of type B aortic dissection, because the descending aorta is the one that is getting involved in this case. And surest sign of antemortem is cadaveric spasm. No, it is not at cadaveric spasm. Please check out your notes carefully and do modify them if they are required. The most important manifestation for drowning in an individual would be not cadaveric spasm, because he may not be able to hold on to something. No, but if the water goes in the lungs, that is a short way that the patient got affected. Anyway, coming back to the discussion, what you need to do in this patient is, Khushi, I would like to bring to your notice that even type A requires immediately surgery, but even in that particular case, you will have to go ahead and perform first give medical treatment in both type A and type B. First thing is beta blockers, because you want to decrease the progression of the tear. I want to make it very, very clear that in type B, immediate surgery may not be required and only medical management will suffice. But for type A aortic dissection, also medical management is to be started before the patient is taken into the OT. For type A, definitive treatment is surgery. But even in type A aortic dissection, initial treatment would be medical stabilization. So in this particular case, we need to give beta blockers, because when you put the brakes on the heart, it will slow the progression of the tear, and after that we can give sodium nitroprusside to the patient. Now why should we not give sodium nitroprusside to the patient initially is because hypertension is a cause, but anytime you are treating anytime you cause vasodilation, there is bound to be a reflex tachycardia. Obviously the reflex tachycardia component will be less as compared to what you get with calcium channel blockers, but any time when you do a vasodilation, there is like, that's how heart will operate. No, that if there is a vasodilation occurring, what you will always notice is a reflex tachycardia, and this reflex tachycardia can then contribute to accentuation or can increase the amount of tear in a patient. So what we need to do in this patient is that first we should put the brakes. The bottom line is, because of the chest pain, sympathomimetic stimulation will occur. Because of the sympathomimetic stimulation, the heart will start beating faster, 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 and once it will beat much more faster, it will increase the amount of tear. So one thing I want to make it very clear before you is that in all patients of aortic dissection, whether type A or type B, medical treatment is of paramount importance. Beta blockers have to be given, and we can institute the treatment for hypertension also. Then definitive treatment of type A is always surgery. In type B, it depends. If medical treatment is stabilizing the patient, cool. If not, then we can go ahead and plan surgery in a patient. So I hope it is very, very clear here. Yes, doc, my job is to correct you, so I thought I should just mention that. So the answer for this question is uh, yeah. No, not exactly. It is the arch of the aorta which is getting involved. So, but here he is not even asking you regarding whether surgical repair is warranted. It is just the fact that in this particular case, it is beta blockers which are being given first in this case. And if you look at option number C, it is enoxaparin that is given. So even if I go by analogy that, okay, it looks like the anterior part of the aorta is also involved, we'll not be giving enoxaparin in this case, because we have to operate on somebody. No, if required, then giving enoxaparin will worsen the patient or will deteriorate the patient. So yeah. That is what I'm trying to say. No, that if the arch is involved in a patient, and if I say that, okay, by classification it becomes, even then the answer C will not make sense, because it is enoxaparin that would be involved. So, but I would be more specific if it is the ascending part of the aorta that gets involved. So this is the I would say the even the lateral part of the arch is getting involved in this patient. So he's not even asking you regarding whether it is type A and type B, but what is being done is what is the initial management in a patient. So the aspect here is that it is a beta and then a vasodilator. It's a beta blocker and a beta blocker, and then it is going to be vasodilation that is needed. Okay, so I'll just write that carefully. Why I'm highlighting this is because in pheochromocytoma it is alpha plus beta, but in this case it is a beta blocker with a vasodilation in this particular case. We'll not, I mean, we will give sodium nitroprusside, that is okay. It is like you can put 2 IV lines in a patient, but what you need to initiate first in the patient would be first start with beta blockers, so that the effect of sodium nitroprusside can be counterbalanced. The reflex tachycardia part can be counterbalanced. Okay, so we are sorted for 111, and I hope I made that clear before you. And I'll show you one more image for the type A and type B part where we'll talk about like where do we really need the surgery or not. But here it is like after when will we give nitroprusside? No, it is like we'll first give beta blocker and then give sodium nitroprusside. Okay. Uh, Moving to the next one, which of the following is correct about myasthenia gravis in a patient? So, waiting for your answers, guys. The main manifestation that you would be seeing in this patient is myasthenia gravis is a disorder in which there would always be a thymic involvement. Last time NEET PG they asked like why would this patient be having myasthenia gravis? So in 65% patients there's a thymic hyperplasia. In about 10% patients there is a thymoma, which is why elective thymectomy would be required in this patient. Okay. So the main aspect is that when we do a repetitive nerve stimulation should be producing a decremental response, which is not the case which is given in this question. What you are seeing in this case is that decremental response is present on repetitive nerve stimulation, whereas here it is written post-tetanic potentiation. Tetanic potentiation would mean that rather it's like causing a spasm, right? I mean, tetanic potentiation is not the technical word here. And then muscle weakness improvement with day progression. It is muscle weakness that worsens with day progression. It's not an improvement, right? That improvement is seen with Lambert-Eaton syndrome. That muscle weakness improving with day progression is a feature with Lambert-Eaton syndrome. So I'm left between option number A and B in this question. The meaning of the word jitter is that the time gap between the two stimulations, like, in myasthenia gravis, there is a insufficient, or like there, I can say there is a incompetent neuromuscular junction. Because of the incompetent neuromuscular junction, what will happen is that there will be a slow conduction, and therefore the gap between the two impulses will increase. So the correct answer in this question is option number A, that is increased jitter on a single fiber electromyography. Meaning of the word increased jitter is that there is going to be a decrease, or there's going to be an increase in the gap between the two muscle contractions that would be coming because of an incompetent or an insufficient neuromuscular transmission. The question is testing your knowledge of English in this case, because traditionally, you see, what I want to bring to your attention here is that the questions that might be coming may not always be straightforward, and they might be playing with English. This is perfect such example of it, because your eyes are searching for repetitive nerve stimulation showing a decremental response. So that is why the majority of people answered this as option number C. But when it comes to single fiber electromyography, which is the investigational choice for diagnosis of myasthenia gravis, what happens is that because there is a poor quality neuromuscular transmission, because of the poor quality neuromuscular transmission, the impulses between the muscle contraction, like your muscle and my muscle can contract again fast. Like let's talk about our blinking. We and me can blink our eyes fast also, fluttering of the eyelids like we can do. So you and me can blink our eyelids fast, but in myasthenia gravis, because there's a insufficient neuromuscular or inefficient neuromuscular transmission, they cannot blink their eyes fast like you and me. And that is the meaning of the word increased jitter, that the gap between the two muscle contractions is increased. So this time this would be an increase in the jitter. So just playing with English, guys. Don't bother about whether you got it right or wrong. Just try to keep on understanding the fact that we have to be sometimes using our analytical skills to get these questions right. The correct answer in this question is option number A. Please just comment in the chat box understood or not understood. If understood, then you can just write a U there quickly so that I can just move on to the next one, because this I think I am not very well highlighted. In my routine discussions I've been mainly vocal about the decremental response because I want to differentiate from Lambert-Eaton. But then I thought that I should, if I'm getting an opportunity, I speak about that increase in the jitter. And that word, that initially first time when you read the word increase in the jitter, it looks like we are talking about some amplitude increase. No, it is not the amplitude increase. It is the time between the two muscle contractions, which would be relatively increased because of a poor quality neuromuscular transmission that would be present. Absolutely, yes. Petrichor, yes, you are right. Okay, so the answer for this question is option number A. And don't bother यार भाई, आसान वाले भी तो करा रहा हूँ यार, तो ऐसा तो नहीं है ना. Like I have to give some that will be tongue twisting. Like I mean, in the exam there will always be mixed bag. Like 10% questions are gonna be like, where they will play with English. 10% will be literally bouncers. So the bouncers have to be left, but the ones with English have to be worked out by exclusion. So this is one such example which I think is like this question is basically a representation or example of the fact that learning is an ongoing process for we doctors all the time. And let's move on to the next one. Okay. This is a 45-year-old woman. She presents with abdominal distension, and then there is the tense abdominal wall and engorged superficial veins. So since he's mentioning the word fluid thrill, it means that there is like ascites present in a patient, and then abdominal paracentesis has been done in this lady as well. So first and foremost, we will be calculating the serum albumin ascites gradient. So serum albumin ascites gradient would be a serum albumin value and then the ascitic fluid value that I'm subtracting. So you can see that the value is coming to be 0.9, that is less than 1.1. The moment you know that the SAG value is less than 1.1, the moment you pick up that the SAG value in this patient is less than 1.1, what you will do is that your thought process will go towards what I've explained to you as TPN. TPN is tuberculosis in India, very common. Then after tuberculosis, the next one to be thought of is 2Ps, peritoneal carcinomatosis and pancreatitis, and is nephrotic syndrome, and B is the biliary leak component. That is the thought process of yours. When TB, peritoneal carcinomatosis, pancreatitis, nephrotic, and then biliary leak. And considering that information, what you will do next is you will analyze the report. So you can see increase in number of cells, and you can see that there is an increase in the number of lymphocytes also. So initially I'm thinking, okay, this is Indian patient and there could be TB, but then one point that is given here is presence of macrophages and mesothelial cells. I mean, mesothelial cells have no business to be in the peritoneal fluid. Considering that these are mesothelial cells, we will first keep a possibility that this lady could be having a peritoneal carcinomatosis, like she could be having a ovarian cancer, and that ovarian cancer could have metastasized to the peritoneum, so it will cause a malignant development of malignant ascites in this patient. And even if you go by logic here, all the remaining conditions which are given in this question, all the remaining options which are given in this question are for SAG value more than 1.1. So if this was tuberculosis given in a question, it would have been a close one. And like that's what I'm trying to sensitize you. I deliberately ensured that the question is relatively easy because you have to work out at only one level, that is SAG value more than or less than 1.1. But yes, do take care of the fact that it can go a little more deeper and can ask you to evaluate with respect to what will be the mathematical value. Thanks for the suggestion. And you have an interesting name. Okay, so macrophages and mesothelial cells, if they're given, then we have to think in terms of malignancy in a patient. I mean, this lady probably has a ovarian cancer of undetermined etiology, and we need to find that out. But yep, the cancer would have spread, and that is the reason why there would be malignant ascites occurring. Okay, engorged veins. engorged super यार ascites में जब टेंस ascites होता है तो engorged superficial veins होती है ना. If you see a patient of ascites, his abdominal wall will be very very shiny. ऐसा लगेगा जैसे abdominal wall पे आप oil लगाया हुआ है. It's not an oil, it's a very shiny anterior abdominal wall. There would be stretched veins, engorged superficial veins. In fact, some of these veins are gonna be like, you'll literally be tempted to put a cannula in them because they're so prominent, right? Normally in our case, the anterior abdominal wall superficial veins would not be prominent, and the umbilicus is everted. जैसे पानी भर जाता है ना, it's like little छोटा सा पानी का गुब्बारा, no? That पानी का गुब्बारा is the umbilicus everted that you would have noticed. So the answer in this particular question would be answered as option number D. And yes, guys, let's focus at the job at hand. We have this young girl. Thank you, Daisar. We have a 18-year-old girl. She collapses during a school assembly. The ECG shows a prolonged PR interval and a broad QRS complexes with a QT of 500 milliseconds. That's a cause of concern because normally the QT interval would be something in the range of about 360 to 440 milliseconds. So we are having a QT prolongation in this case. I think everybody could pick up that this cannot be Wolff-Parkinson-White syndrome, because Wolff-Parkinson-White syndrome will always be having is a short PR interval. Along with short PR interval, there would always be a delta wave that can be present in these patients. And along with this, there might be a PJ interval that is usually going to be normal. So as far as WPW is concerned, the main point against Wolff-Parkinson is that the word prolonged PR interval is given in this question. And when it comes to Lown-Ganong-Levine syndrome, this again will be having is a short PR interval. And the PJ interval in this particular case is reduced. The PJ interval in this particular case is reduced. So if you go by exclusion in this particular case, the condition is Romanov ward. Romanov ward always causes a QT prolongation. It's a potassium channel defect which is seen Romanov ward, and this potassium channel defect results in a QT prolongation in a patient, and therefore polymorphic ventricular tachycardia. can occur in these patients, torsitis de pointis, and that could be one of the contributors to development of death in these patients. So yeah, QRS is normal. Because QRS is normal, that is why Lange-Levine syndrome, the PJ interval will be relatively short. So this question was just testing your knowledge, and you guys have done this very, very beautifully. Is that prolonged PR interval, right? That's the keyword which is to be identified, that it's a short PR interval versus a prolonged PR interval. The sequence is Ruskin board. I'll just address you here quickly because this will this will help a lot of students. Is that first you should be listening to the video lecture, because then you use three parts of your brain. You hear, so that is gonna be temporal lobe. You see, that is occipital lobe, and you analyze because nodes are flashing in front of your eyes. That is gonna be your parietal lobe. So you Bhagwan ne four lobes diye, you're using three lobes of your brain. So when you listen to a video lecture, it makes you more receptive because three lobes are being used. And then subsequently you can read the same topic from Davidson or from Harrison, or if you want to use Hutchinson clinical methods for learning the clinical domain, I mean, be my guest. But listening first to the video lecture would give you much more insight into the core things that you are supposed to focus in the book. Because suppose you open a book, no, then you don't know what to read and what not to read. There is so much of pathophysiology, there is so much of clinical information given, that it causes a lot of distraction in the mind, and we tend to waste our time reading that segments that really don't matter. Like here, what we did was, like, if you listen to your seniors, like they beautifully were excluding out option A, B, and D, because they know what they have to focus is short PR interval in the question. Now, how do you get that skill? Is by listening and then subsequently going through the data. So that is taken care of. Wolff-Parkinson type A is the abnormal. Okay, good question there. I think I've explained it in the main videos, but just came up in the chat, so I should quickly just mention it here, that the abnormal circuit would be left-sided. I mean, the current of the abnormal circuit which is connecting the atria and the ventricles would be left-sided. So if the bundle of Kent which is present is left-sided, so the left ventricle will get activated first, and the right ventricle will be activated later. So it will behave like a right bundle branch block. So bundle of Kent on the left side is what is written as WPW type A, and when it comes to WPW, it can be type B also, that the bundle of Kent can be present on the right hand side. Like, I'll use a different color to just make it, like, suppose this conduction is occurring from this side, then if it is going to be right sided, then right ventricle will get activated first and then the left, so it will behave like left bundle branch block. So the behavior of both from the perspective of heart sounds would be different, and that is why, like, we are reading about this type A and type B Wolff-Parkinson-White syndrome. The answer to this question is option number C, and I hope it is clear now for that differentiation that I have mentioned. Okay. We have this long stem question now, where we have a hypertensive patient with heaviness in the chest wall and shortness of breath on climbing stairs. So exertional chest pain is coming in this guy. The BP is fairly elevated, 180 by 110. That would need at least some medication to be given. He has already been treated in a hospital last year, and he's discharged on oral medication. So which is the best one for the diagnosis of this patient? Okay, so this patient is having exertional chest pain. So my current clinical diagnosis is that this guy is having a chronic stable angina. In the past medical history of this patient, there is one episode of acute coronary syndrome. When I say the word acute coronary syndrome, it would be either a myocardial infarction or it would be a unstable angina occurring in this guy, but medical treatment for the same has been given. Now he's saying that in this particular case with chronic stable angina, because I want to evaluate whether this guy is having triple vessel disease, whether he's having double vessel disease, I need to scan. I mean, my objective is scan the coronary arteries of this patient, because I want to identify that is he having single vessel, double vessel, or a triple vessel disease. And to scan the coronary arteries of the patient, I have a couple of investigations which are given in this question, and this would help me identify that what is to be done. Now, to scan the coronary arteries of this patient, one of the main tests that would be done would be a CCTA, that is a coronary CT angiography. No guys, it will not be invasive, no, because coronary angiography is invasive. And lots of time people do not agree for an invasive test. So what we do in our patients is CCTA, that is a coronary CT angiography. This coronary CT angiography is a non-invasive test. It has a diagnostic accuracy. If you listen to the video, it has a diagnostic accuracy of over 98%. Whereas the gold standard investigation that we talk about, is an invasive coronary angiography, which will obviously be having is a 100% accuracy for detection. So we are basically debating regarding what we will be doing in this patient, that is option number B or option number C. Troponin I is ruled out in this question because he is not having acute chest pain at the moment. Stress echocardiography is contraindicated due to elevated blood pressure in this patient. I mean, this guy's BP is already elevated. If I give him dobutamine, it can cause a further spike of blood pressure, and that can even cause a hypertensive crisis or some kind of a CNS event in a patient. So the reason why I'm not doing a stress echocardiography, if it is a stress echocardiography that is being done, it can increase the blood pressure in this patient. So he says, which is best for diagnosis of this patient? Then we'll first go by CCTA, that is a coronary CT angiography. And then subsequently, like if we find that there is presence of heart, because he's already on oral medications, no, so he might be already on statins and he may not be requiring any medication as well. So we don't put stent in everybody. We check out whether there is a narrowing present in the artery or not. Like if the narrowing is 50%, 60%, then we don't need to go ahead with putting even stents in the patient. It's not that every patient will require a stent. No, if it is early part and when you tell about stent, people don't agree for it unless and until it's a very educated person who understands the consequences. I mean, you would be like, you would see all around, people are get diagnosed with single vessel disease, double vessel disease. The cardiologist might say for stenting also, they don't agree for it. So what we'll do in this case is, what is done in this patient, that would be answered as coronary CT angiography, that is CCTA. Sir, best is investigation choice. No, gold standard investigation is something that a person may not agree to. When you will tell somebody that I will puncture your radial artery, or if I will take access through your femoral artery, the patient will run away. So best is okay, but then best does not mean the fact that he is gonna agree to whatever you are saying. So we have to be practical in this case, and therefore the answer in this is coronary CT. CCT is what? Coronary CT angiography. CCT is coronary CT angiography. Yes, if not elevated BP, I would have done a stress echocardiography in this patient first, and then subsequently we can take a call on whether we want to put him on medical therapy or we want to evaluate this guy further by scanning the coronary arteries of this patient with the CCT only. So the answer in this case would be given as option number B. I know it will cause a bit of distress in your mind, but if you check out the actual videos, then you will be able to understand this. Yeah, Octavius, I understand ये दुविधा है और ये दुविधा रहती है, but then we'll have to take it at the face value. What is to be done practically is what is to be answered. Okay, moving to the next one, we have this patient to the emergency room with sudden headache, described as the worst headache of their life. Yeah, MBBS life. You have a point there, no? So that is why I did not mention regarding stress echocardiography in this case. Okay, so the patient is having worst headache of their life. We're talking about a subarachnoid hemorrhage in this case. A question of this kind also came in just the recent INISET exam as also. Like the patient is having a non-contrast. We are suspecting a query subarachnoid hemorrhage. And he says because of the fact that the CT scan is normal, that is why what should the doctor be doing next in this patient? Okay, so cerebral angiography is done if it is confirmed subarachnoid hemorrhage. The answer is not option number C. Last time's NEET PG, the question was like, if a person is having subarachnoid hemorrhage confirmed by non-contrast CT scan, what is the next investigation to be done? Then it is to be answered as cerebral angiography. So this is not that same question, which is why option number C is being ruled out. Then is time of flight magnetic resonance angiography. So I mean that MRI is not going to give some high amount of information, because MRI is good for ischemic. But for hemorrhage, it is CT scan only. Na? For hemorrhage, it is a CT scan only. So what we will do in this particular patient is that we will be not repeating the scan, because that might be after 24 hours, the diagnosis will be missed. So what I can plan in this patient is a lumbar puncture. And because I plan a lumbar puncture in this patient, there would be xanthochromia, because if there is even microscopic RBCs present, like they may not be, it may not be a bloody CSF, but if those microscopic RBCs are now getting broken down, then level of color of the CSF will start changing towards yellowish, and we can identify that some RBCs can be seen on a microscope as well. So answer for this particular question would be option number B. And lumbar puncture is invasive, sir. I think you going through skin and you are poking the patient's spinal canal, you can still convince a patient, because the headache part is very much there. If somebody is not having chest pain right now and you tell him I will puncture your artery, if I come to you and you tell me, sir, I'll take your femoral artery access, I'm not going to listen to you, right? But here the person is suffering, so person will listen to you, and a lumbar puncture would be done in this particular case. Mani, you have a point. Any chance that the intracranial pressure in this patient is more? Yeah, so we will be doing a guarded lumbar puncture in this case. And let's just analyze this information here. There are two aspects which I want to say here. In subarachnoid hemorrhage, if there is documentation of blood in the sylvian fissure, like the question mentions subarachnoid hemorrhage, blood in the sylvian fissure, and he says what is the next investigation to be done, we will tell the patient that there could be a berry that has burst in you, and there could be more than one also. So second one is like a time bomb waiting to explode. So give me permission so that I can take you to the cath lab and do a cerebral angiography. So in subarachnoid hemorrhage, documented, there is always going to be cerebral angiography. If the non-contrast CT scan of the patient is normal and he says what is the next investigation, it is lumbar puncture. Lumbar puncture will be done to check for RBCs in the CSF and to demonstrate the presence of xanthochromia, since a couple of hours would have passed by for in the patient. The correct answer for this particular case, overall the leading cause of subarachnoid hemorrhage, doctor, is always going to be answered as trauma. But most of the cases, like the cases that given to us, are like patient wakes up with a headache. So this guy would have had a berry aneurysm that would have ruptured. Overall, coiling is always superior as compared to clipping. That is a perfectly correct statement that is given in this case. The answer, so order, yes, CT then LP. No, 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 no. There are two different chain of thoughts. No, it is blood in the sylvian fissure, cerebral angiography. If person does not give consent for cerebral angiography, then I can go for a CT angiography or a digital subtraction angiography, as you were saying. Suppose I don't get a consent for cerebral angiography because it's again invasive, so we will be doing a CT angiography in a patient. So that's the sequence for a documented. If we are having blood in the sylvian fissure, a CT angiography next, and if it is undocumented subarachnoid hemorrhage, then a lumbar puncture next. Yeah, non-traumatic would be a berry aneurysm rupture, right? Yeah, QT changes, tropa elevation that we've discussed, that is in pathomimetic stimulation, because excessive catecholamine release is occurring in the patient is why this would be answered in the patient. Papilledema requirement assessment before lumbar puncture. Yes, yes, absolutely, Akargoel. Before any lumbar puncture, we should always be ruling out raised ICP, because after, like any case of meningitis, like should we go for a lumbar puncture or should we go for neuroimaging first, is based on if there is presence of any seizures. You put up a valid point, so I'll just mention that quickly here. Like suppose a patient of suspected meningitis has come in the hospital. So though I've discussed this in rapid revision, but because it came up, so I just want to say that should I go for a lumbar puncture or should I go for a neuroimaging in a patient? So if the question is mentioning the following statements, if he says meningitis patient had seizures, it is neuroimaging to be given. If he himself mentioned by saying AIDS patient and immunocompromised treatment is given, then it is again neuroimaging which is to be given. If the fundus finding of papilledema, like we'll do a fundus examination and that shows a papilledema, that is indication. If there is some focal deficit which is present in a patient, focal deficit would be like a arm weakness or leg weakness present, then it is neuroimaging first and then a lumbar puncture, and that too a guarded lumbar puncture that would be done. I mean, that was just a question from the perspective that what of the two should be done. Uh, okay, so I've explained this multiple times that we always do lumbar puncture. It's a guarded lumbar puncture. We don't withdraw the stellate immediately. If there is presence of papilledema, we first give mannitol and lower the pressure in the brain and then do a guarded lumbar puncture. So you are right, lumbar puncture is also invasive and increase ICP, so it is not recommended. But the lumbar puncture is done. Why and how it is done is what I've explained to you. First, check out whether there's a papilledema. If it is present, give mannitol. Let the drug act and lower the pressure in the brain, and then you do a guarded lumbar puncture with the thinnest possible needle. And when you do a guarded one with the thinnest possible needle and let the CSF escape drop by drop, you will bypass that side effect of risk of coning of the brain or brain herniation. So I hope that will make it clear. Parmar, you have a very good point, Dr. Parmar, that xanthochromia will take 24 hours to develop. It starts as early as by the 6 hours. So if you check out the notes, xanthochromia full blown will take obviously much more time, but initially it's gonna start in like within the time frame of 6 hours only. Okay, answer for this is option number B, and we move to the next one. We have this alcoholic coming with palpitations and dizziness, and on examination there is like a fast rhythm which is irregular. I mean, that immediately tells me that the question is on atrial fibrillation, and there is bilateral crepitations also described in this particular question in both the lung fields with elevated B and P. So he says what drug would be recommended for this patient. Because this is a repeat one, guys. This was asked in last time's paper also. Atrial fibrillation, having acute heart failure. So we would not be giving beta blockers to this person because beta blockers are contraindicated in patients of acute heart failure. The reason why we are not giving beta blockers is contraindicated in heart failure. Diltiazem will have a negative inotropic effect. In fact, it will act on the AV node, no? So it will have a negative chronotropic effect. Diltiazem will be having a negative chronotropic effect, that is okay. But then at the same time, even that would not be very, very beneficial in a patient of, that is going to be causing damage in a patient of congestive heart failure. So again, not recommended. The answer in this case is digoxin because it will help in controlling the irregular rhythm by causing a vagal stimulation. And clevidipine has a side effect of again causing a reflex tachycardia. So if you look at the options here, and even if I don't go into much of details, it is like digoxin would be used. For atrial fibrillation, for rate control, it is always esmolol, which is to be answered. The first time they introduced a trick in the question was they mentioned a patient of atrial fibrillation. The person was having a thyroid storm. The reason for atrial fibrillation was that the patient was having a thyroid storm. And then they mentioned that this guy is having bronchial asthma also. So because of the fact that bronchial asthma was also given in the question of atrial fibrillation due to thyroid storm, and there was asthma described, so it is calcium channel blockers that would be used. That was NEET PG 2023, I think. And last time that the question that was put up was atrial fibrillation. No, it would not be propranolol, guys. It is calcium channel blocker that would be given for rate control in this case. And atrial fibrillation, then due to acute heart failure, then it is digoxin to be used. So two tricks are what they have tried to play in this particular case. Adenosine would be given for this case. Adenosine would not be recommended in this patient, doctor. Adenosine is a drug that is used for management of PSVT. So we were having multiple versions of the same question. So there is a possibility that if the app had selected, because we feed the data into a database and then we let it select. So sometimes it's a possibility that if it was a question on a PSVT, then adenosine would have been in the options. But otherwise, it goes with digoxin only. So the answer in this case is option number C. I hope it is clear, guys, that the main aspect is that these two fundamental issues are to be remembered. Like they gave a question of atrial fibrillation patient in a thyroid storm. He said कि पहले क्या करेंगे? So first we have to give calcium channel blockers and propranolol again. In an asthma patient में तो फिर propranolol नहीं देंगे ना. Like somebody commented in the chat box propranolol. So just want to say कि भाई asthmatic में तो फिर beta blocker वो भी non-selective beta blocker would not be given. So I hope it is clear. Okay. Moving to the next one, we have a look at the ECG of this patient. If you scroll through, will be digoxin. Yes, atrial fibrillation with acute heart failure. Doctor, I just want to correct you here. No permutations apart from the two that are mentioned here. It is total three permutation combinations for the rate control. I mean, what they're trying to play with is English only. Na? Beta blockers are contraindicated in ABC. I'll just mention the, since you said what more permutation combinations are possible. So I'll just say like this, beta blockers are contraindicated in ABC. So by A, I mean acute heart failure and acute asthma. By B, like you asked a combination, so I'm saying heart block. Like there could be a possibility that the question could be mentioning regarding heart block in a patient. Any variety of heart block, I will not give beta blockers in a patient. So the trick is he could mention like beta blockers contraindication is what I'm trying to just say before you, and then can be COPD. So because we're talking about tachyarrhythmia in a patient, so unlikely that B would be there. But acute heart failure, acute asthma, and COPD are the common contraindications to beta blockers that I want to bring to your attention. Obviously, bradycardia would not come in the discussion because we're talking about a tachyarrhythmia, so not a bradycardia or heart block would come. Okay, diabetes. I think I've explained beta blockers are given in diabetes mellitus because they reduce mortality in a patient of chronic stable angina, and that is I would say a relative contraindication. In real practice, we give it. No, so from pharma, it is understandable that beta blockers will mask the symptoms of hypoglycemia, but that would not be a statement that would be holding grounds in the actual clinical domain. Yes, that's the point I'm trying to say, that masking of hypoglycemia is not a side effect that is to be taken. In an era of continuous glucose monitoring, why should you let somebody suffer from hypoglycemia? No, they put on a patch and they can see the blood sugar in their mobile. So if you notice somebody is having a hypoglycemia, ask him to take something sweet. Why to say to him, oh, you will miss the symptoms of hypoglycemia, so will not give a beta blocker. So I think I have explained that already. Yes, decompensated heart failure. It is decompensated heart failure. Okay, so let's focus on the current ECG that is given to you, and you will notice that the PR interval in this patient is remaining constant only. There are no changes in the PR interval. It's a normal sinus rhythm that is coming up, and the PR interval is fairly decent. It's not showing any significant changes. But what you can notice in the ECG is that P wave is absent the first time and then another time. Yep. So P wave is coming but is intermittently disappearing. So what I will say in this particular case is, because the P wave is missing, P wave is absent in this case, and we are also having is the bradycardia. Like if I put the boxes here, it would be 1, 2, 3, 4, 5, and going up to 6 for calculation purposes. So I can say that there is a heart rate which is usually hitting 60 or little less than 60 per minute. So the answer in this case would be given as 6 sinus syndrome. BNP is B-type natriuretic peptide. BNP, for the previous question, somebody asked what is BNP? B-type natriuretic peptide. That's always a feature of heart failure, no? I mean, that itself is a hint about the fact that the fast beating heart, the oxygen consumption of the heart is more, so the heart is failing as well. And that's a standard feature of alcoholic, because dilated cardiomyopathy will occur. Okay. Yeah, Parmar, you're right. Atrial fibrillation, 6 sinus and hyperkalemia is where the P wave would be absent in a patient. Good pick up there. Answer to 118 would be option number A. A complete heart block will be having unequal PP and RR interval. No, like suppose I give you a ECG like this, and what I'm showing is P followed by a P, and then is a broad QRS complex, and the number of P waves and the number of R waves is not matching, then we'll say it is a complete heart block. No, the PP interval, the distance between the P and the P, and the distance between the R and the R is not equal. That's the presentation that you get with the case of complete heart block. So I mean, this option is ruled out. Complete heart block is ruled out because the PP and the RR interval is unequal. Okay. Moving to the next question for today. This would be a patient with diabetes mellitus brought to the hospital with left-sided face and arm weakness, with arm weakness when more than the leg, developing 2 hours after waking up. And then the BP is super elevated, 200 by 100, and the non-contrast CT head is shown below. We can see a hypodensity which is present in the frontal and is extending into the parietal lobe as well. So hypodensity is present in this case. The patient has arrived at the hospital at 6 p.m. and symptoms have occurred at around about 2 hours after waking up at 6. So at the arrival time, or I can say the window period in this case, is more than 6 hours. The window period in the patient is more than 6 hours. There are two informations that you're picking up. This is a case of acute ischemic stroke because we can see that there is a hypodensity that is present, and the window period in the patient is more than 6 hours, and he says that which of the following is best suited for management of this patient. Yes, guys, let me know what would be your thought process for this one. Lowering the blood pressure of a patient is done to less than 185 by 110 if a patient is a candidate for thrombolysis, but this guy is outside the window period for thrombolysis, so we will not be doing thrombolysis in this case. You see, there is no role of CT angiography because CT itself is showing a hypodensity. CT angiography is done to identify a large vessel stroke in a patient, that is to document whether there is like a LVO occurring in a patient or not. So there is no role of CT angiography because CT is showing a evidence in this patient, and then lowering BP with labetalol is done if patient is candidate for thrombolysis. In this patient, person is outside the window period for thrombolysis, so option number C can be ruled out. I'm left between option number A and B. Obviously, I like A is ruled out, so the answer would be endovascular treatment. In this case, the answer is option number B. And what you mean by endovascular treatment is that we'll take this patient up in the cath lab for MRSI. MRSI would be mechanical embolus retraction in cerebral ischemia, where we remove the clot, which is contributing to the manifestation in this occurring. Yes. Yes, hence a thrombectomy would be done in a patient. Exactly. So the word thrombectomy was not there. It is endovascular treatment that would be given in the patient. Yeah, hadbadi mein gadbadi. That's how you can call this. Okay. Just going ahead, I want to say that if a patient of a query, uh, if a patient has come, like if he mentions that patient comes with face and arm, and suppose he says like weakness, like if this is the kind of a question that is given and the history given is a 1 hour or 2 hour, and the non-contrast CT head in the patient is normal. Like he says, CT head in the patient is normal. Now, CT head can be normal in a patient also because of the fact that CT scan findings in acute ischemic stroke will take good about 6 hours to appear. So, yeah, clinically, like we can start this patient on thrombolysis, but then the issue is this person could be having a transient ischemic attack also, and we might actually miss that fact that he is having a TIA. So in this particular case, if the CT scan is normal in a patient and he says what is the investigation that can be done subsequently, so we can plan a CT angiography in a patient. I mean, obviously, I would like to do a diffusion weighted MRI, like because in any patient of acute ischemic stroke, if we do a DW MRI, it is best enough. But then DW MRI facility may not be available anywhere. So what we can do in this patient is do a CT angiography that will help us to identify whether there is a evidence of a large vessel stroke in a patient, LVO. And if CT angiography shows evidence of a large vessel thrombolysis, large vessel occlusion, that is when we can plan is the LWS in this patient. So just want to bring to your attention that if it is going to be a CT angiography, CT is normal, and you have to differentiate between TIA or acute ischemic attack. Then the next investigation that helps you in differentiating is the CT angiography. That is if diffusion weighted MRI is not given in the options. Okay, so the answer in this particular question would be endovascular treatment. Just check out here other time to stroke के questions में ना they would always be endovascular treatment that would be given. I'll just invest 15 seconds into Mobitz 1 and Mobitz 2 heart block because this was a question that came up. I don't want people to mess up on that. So बस इतना देख लेना if the PR interval is showing a prolongation. If the PR interval in the patient is showing a prolongation, then it is Mobitz 1, and then you will notice a drop beat happening in the question. So this would be T followed by P, and then there would be a drop that is happening. All just check out is like I'm not getting into the exact details because this is just before the exam session, but I just want to bring to your attention that if you get a question in which the PR interval is showing a serial prolongation, then and there's a drop happening, so you will say it's Mobitz 1 heart block. But suppose like everything is normal, don't lose patience, because most of the time people lose patience is movements to heart block. So everything is normal, and then there is gonna be like a sinus arrest kind of a thing happening, which will look like a sinus pause, and that's where there's a missed beat occurring in a patient. So the PR interval does not show a serial prolongation; it would be movements to heart block in a patient. So I just wanted to bring to your attention two ECGs here for Mobitz 1 and Mobitz 2 that have been asked, and more likely to ask Mobitz 2 heart block because there everything is normal. And also I want to bring to your attention that it may not be necessary that only after 2 or 3 conductions there will be a there would be a presence of like drop beat. It could be like 3, it could be 4, it could be 5, it could be 6, and then in an abnormal fashion or like in a asymmetrical pattern the drop beats are coming in a patient. Okay. हाँ, अगर ये पेशेंट, अगर जो ये वाला क्वेश्चन है जो अभी अभी इन्होंने पढ़ा, अगर इसमें पर्सन जो था वो सुबह सुबह लाया गया होता तो मैं इसमें पहले ब्लड प्रेशर लोअरिंग करता. लाइक सपोज द पेशेंट वाज इन द विंडो पीरियड, देन आवर आंसर वुड हैव बीन ऑप्शन नंबर सी फॉर दिस पेशेंट. एंड I mean first, if he said first, best treatment would have been thrombolysis only because he's a candidate. If he said what is first, then lower the BP with labetalol. Patient is outside the window period, so that is why the answer will change to endovascular treatment. Window period summary, doctor. Window period is 4.5 hours ideally. Upper limit is 6 hours only, and after 6 to 24 hours we treat with endovascular treatment. और अभी तो देखो अपडेट आ जाएगा यार, मैं बता रहा हूँ स्ट्रोक के हर पेशेंट में झंझट खत्म हो जाएगा. दे विल से कि सारे के सारे स्ट्रोक के पेशेंट्स में ना इररिस्पेक्टिव द विंडो पीरियड सब में पहले थ्रोम्बोलाइसिस दे दो क्लॉट को सॉफ्ट करने के लिए और फिर मर्सी कर दो. Ideally, what they do in America is for any patient of stroke that is coming, no, first they give medicine to soften they give medicine in the ambulance. They're setting up a, like in America, what they're doing is they're setting an ambulance system that will reach the stroke patient's home, right? And they have like their protocols established. Once they establish that the person is having a AIS in the ambulance itself, the thrombolysis part may be started. That is to soften the clot, because most of the time thrombolysis is not able to destroy the clot. So it's like soften the clot and then bring him to a stroke center and do a cath lab procedure, that is take the excess from the femoral and remove the clot in the brain. So mercy will subsequently, or like endovascular treatment will become the main treatment for all varieties, but that is for the subsequent years to come. At the moment the data has to be as what I've said. Okay, sepsis is defined as SIRS plus positive blood culture is what I'm getting as an answer. This is a old definition. SIRS plus positive blood culture is defined as sepsis. The current definition is option number A, that is 2-point increase in the SOFA score of a patient, that is sequential organ failure. Depth of heart, why not angiography to localize the clot? Can you let me know, doc, in which question are you talking about that? You are talking about the stroke patient, angiography to localize the clot right away? Cerebral angiography may not be available immediately, no? So we do a CT and a CT angiography then subsequently. Okay. The new definition of sepsis is, I have explained this multiple times, is the 2-point increase in the SOFA score over a serial examination. In a SOFA score in a patient, we will be evaluating the mean arterial pressure because we'll be evaluating the heart of the patient, we'll be evaluating the lungs, the brain, the liver, the kidneys, and obviously the hemorrhage system, that is the platelet count in a patient. In a sequential organ failure assessment, we'll be checking the heart of the patient. What I mean by checking the heart is the parameter that will be assessed by you will be mean arterial pressure. For the lungs part, it will be PaO2 FiO2 ratio, that is ARDS, na? PaO2 FiO2 ratio. बच्चे ऐसे ही होता है, we are not able to remember everything. You are just have to sit and persist. Na? The objective of the session is just to persist. Then for a brain, we will be evaluating the GCS. Yes, CT angiography before a mechanical thrombectomy. In fact, we can do a CT angiography or a CT perfusion study na, before a mechanical thrombectomy. CT perfusion will be better as compared to CT angiography to check for, I mean, CT angiography तो पता चली गया कि भाई there is a clot present. CT किया तो उसके IV contrast तो दिया. तो भाई नॉर्मल जब आप करते हो CT स्कैन उसमें IV contrast देते हो, CT angiography हो गया. तो उसके CT perfusion to see if there is a benefit of perfusion and then subsequently a thrombectomy would be done. Okay, so yeah, there's a quick SOFA and a SOFA. So what we talk about is the mean arterial pressure, PO2 FiO2 ratio, GCS. Then we talk about bilirubin. We talk about KFT in a patient. That would be the serum creatinine. Yeah, there is a difference. No, one is a quick SOFA, and the second one is gonna be, and platelet count in the patient will become subsequently lesser. No, we don't lower BP before endovascular surgery. No, there is no risk, no, because you just take a vascular access. So lowering a BP before is not. In fact, I would suggest you, if you're having any issues with this, it is recommended to listen to fast and rapid revision to the contraindications to thrombolysis. All contraindications of thrombolysis where the BP is not getting controlled, you again do mercy in the patient. So for before mercy or before doing a thrombectomy, there would be no need to lower the blood pressure in a patient. Okay. Okay, so 2-point increase, that's the updated aspect which is to be remembered. Like in angioplasty is only possible after angiography, then endovascular intervention is possible. Cerebral angioplasty. Doc, you'll have to send me an email for me to understand your query better, but the algorithm is like this only. If the BP is under control and patient is candidate for thrombolysis within 6 hours, cool. Otherwise, we straight away proceed with mechanical thrombectomy, even in the first 6 hours if the patient is having contraindications. CT angiography is right. Let me just check. Okay, so somebody asks for why not, answer is option. If CT is showing a hypodensity, if CT is showing a hypodensity in a patient, then there is no need to do a CT angiography in a patient. I mean, he says what is best suited for management of this patient. No, so I have to treat the patient. No, he's not asking what is the next step in management. I have to treat the case. If there is a case of AIS, and I have to treat the patient. And as I said, after 6 hours, the more important study is not a CT angiography, it is CT perfusion. And then subsequently, we will have to best manage the patient by doing a thrombectomy. Okay, Ji. So we are sorted for this one, guys, and moving to 121. This is a question I deliberately kept because I wanted to bring to your attention that the question is regarding immediate management of a Stanford type A aortic dissection, and the BP is super elevated again in this particular case. So first, what we need to do in a patient is, before we take him to the OT, we can give beta blocker to reduce the propagation of the tear. The objective is decrease the propagation of tear. This is a concept which has to be clarified, because I agree to the fact that in type A main treatment is surgery only, but that does not mean that we'll leave the benefit of the drugs behind. In type B, drugs may be successful and surgery may not be required. So importance is surgery is must for type A and may or may not be required in type B. That is one concept. And second is, in all, we should be giving a beta blocker in a patient. Okay, so the answer in this case would be given as option number A. Sorted. So we have this 25-year-old female with palpitations and dizziness, and she's playing lawn tennis, and she's had multiple episodes like this in the earlier part of her life as well. Our ECG is shown. He says what is correct about the histopathological findings in this particular case. Yeah, treatment is being asked. No, but say if the stroke patient is having a manifestation, then you have to treat the patient. No, if it's the next step, then the answer will change. Okay. So what we are seeing in the ECG of this patient is epsilon waves. I'll just try to hand draw them as well. This is P R, and then what we're noticing is this epsilon wave that is coming up. Okay. I'll just sketch it once again. Meanwhile, you can keep on commenting on the answer. In fact, there's a T wave inversion present here. So what I've drawn is just try and draw and sketch the epsilon wave, which is a feature that is seen in arrhythmogenic right ventricular dysplasia. And because the name itself is self-explanatory, that there is ARVD, arrhythmogenic right ventricular dysplasia with the epsilon wave, we have to select the correct option as option number A in this case. That would be a fibropathy replacement on a cardiac biopsy. As far as B is concerned, helter-skelter appearance of myocytes, that would be hypertrophic cardiomyopathy. The ECG evidence in this case would be the depth of the S wave in V1 and the height of the R wave in V5, V6 would be usually more than 35 millimeter, which tells me that there is evidence of left ventricular hypertrophy. So if they give you a question in which a chamber enlargement is given, that too the size of the left ventricle cavity is smaller, and the ECG shows evidence of a left ventricular hypertrophy, then I'll answer it as helter-skelter appearance of the myocytes. A hypertrophy of the myocytes with fragmented nuclei. This is a feature that is seen with dilated cardiomyopathy. Mark my words there. In dilated cardiomyopathy, the compensatory, most of the myocytes are destroyed. So due to toxins like alcohol, so the remaining myocytes will exhibit a hypertrophy. So hypertrophy of the myocytes with a fragmented nuclei would be present with respect to DCM, that is dilated cardiomyopathy. And dilated cardiomyopathy will be having a chamber enlargement like left atria, or it could be a right atrial enlargement. So the ECG finding in this case can be an increase in the duration of the P wave, or it could be like an increase in the height of the P wave that could be present. So chamber enlargements would be present with respect to left atria, and left atria gross super dilated in a patient. And then is amyloid deposition between the myocytes. That is always feature of restrictive cardiomyopathy. And restrictive cardiomyopathy can not only be having chambers that would be normal size, it could be having is a low voltage ECG as well. The correct answer in this case is option number A. Amyloid deposition between myocytes is ninja star may not always be present, man. That ninja star may not always be present. So it's like a hypertrophy of the myocyte, because when they give you that image, it will not always be the titin mutation. Na? If there's a titin mutation, then you get a ninja star, but it's not always going to be a genetic basis. Now, most of the time, patients who are coming would be alcoholic cardiomyopathy. So in alcoholic cardiomyopathy, if you're trying to look for the ninja star, it will not be present. So what do you check for? You check for hypertrophy of the myocytes there. The correct answer in this case would be option number A. Okay, yes. Let's move on to 123 here. We have this man, he's having a palpable purpura. The moment you read palpable purpura in a child, you think in terms of Henoch-Collin purpura, but it is a man, and he's having a palpable purpura. Along with this, there is presence of joint pain that is given in this case. There's livedo reticularis. That immediately tells me that the question is on some kind of a vasculitis. Livedo reticularis is that mottled appearance of the blood vessels on the legs of the patient, which tells us that there's like a presence of a vasculitis that is given. And then we are also noticing that the person is ending up with the development of hematuria with the RBC casts as well. And the biggest hint in this question is that there is a past history of hepatitis C which is present. So what we're talking about in this case is a extra hepatic manifestation of hepatitis C. This is not a case of IgA nephropathy, because IgA nephropathy will not be presenting with livedo reticularis and the arthralgia component which is present. Henoch-Collin purpura is going to be mainly with respect to a child, and there would be like abdominal pain that would be described in the case as well. IgA nephropathy mainly presents with recurrent episodes of hematuria. So two options have been ruled out, and we are left between two. That is essential mixed cryoglobulinemia, and the second is gonna be that serum sickness part. And the correct answer in this patient would be given as option number A. Essential mixed cryoglobulinemia is a extrahepatic manifestation seen with hepatitis C. No, not because of hepatitis C. It's the triad which is present. No, it is the triad which is present in this case, right? So it is the Meltzer triad which has to be picked up. The reason why the answer is not is because of hepatitis C. It is because of Meltzer triad that you get a combination of purpura and arthralgia, and then vasculitis manifestations of weakness and constitutional symptoms which are given in this question. So it is not only hepatitis C. That's just a hint in the question. It is purpura, arthralgia, and the weakness, which is the reason why the answer for this question would be given as option number C. Yes. Yes, serum sickness will mainly contribute to only cutaneous manifestations, no? But then here it is like palpable purpura, then there's arthralgia given, and subsequently even the kidney is getting involved in this patient. So vasculitis is the reason in this case. Okay. We are coming to that question. It is not serum albumin, bache. It is urine albumin that will differentiate. It is not serum albumin that will differentiate. The question will come up in a few minutes from now. It is urinary albumin, because in chronic kidney disease we check for, I think this was an FMG exam question, differentiation between acute kidney injury and chronic kidney injury. Serum creatinine दोनों में बड़ा होता है. I'll come to that question, right? But the answer is not serum albumin. It is urinary albumin, not serum albumin. हेनॉक्स कॉलिन पप्यूरा के साथ में भी सेम होता है. देन हेनॉक्स कॉलिन पप्यूरा में हेपेटाइटिस सी नहीं होता ना, लेवेडो रेटिकुलरिस प्रेजेंट नहीं है. So and that would usually be a child. Okay. इफ नॉट गिवन इवन देन यार, पहले तो एडल्ट का है ना, वही तो बोल रहा हूँ कि पहली जो लाइन है ना, उससे मुझे लगा कि ये हेनॉक्स कॉलिन पप्यूरा होगा. और क्योंकि यहाँ पे हेमाचूरिया था तो मुझे लगा कि बर्जर भी हो सकता है. फिर मुझे लिंक करना ना दोनों को कि भाई एडल्ट पेशेंट है, हेपेटाइटिस सी का एसोसिएशन है. तो अगर ये बच्चा होता तो मैं हेनॉक्स कॉलिन पप्यूरा इसको कंसिडर करता, माइनस द लिबिडो रेटिकुलरिस कंपोनेंट. एल्ब्यूमिन या यूरिनरी एल्ब्यूमिन विल बी इंक्रीज्ड इन chronic kidney disease ना. सीकेडी की ग्रेडिंग नहीं होती है G1 G2 A1 A2 A3. सो एल्ब्यूमिनूरिया ही तो होता है वो. इट इज एल्ब्यूमिनूरिया विच इज प्रेजेंट देयर. ओके. I think I did not miss anything. Fine. We are having this particular patient, Subankar. I'll address you. Urinary albumin is increased in chronic kidney disease. Na? Grading of CKD is G1, G2, G3, G4, G5, and then is gonna be A1, A2, A3. So that is albuminuria. Okay, the next question is regarding pulsations in the neck. That these pulsations in the neck could be due to canon A waves that are occurring in this patient. There's a narrow QRS tachycardia, so there's a supraventricular tachycardia that I'm suspecting in a patient. In high probability, this would be due to circus movement of PSVT. And he says what will be best done to prevent such a recurrence of these episodes. So because he's talking about prevention, so our answer would be catheter ablation, because we need to take care of that circus movement which is occurring in this case. If this question was how do you manage an acute episode, then it would be given as adenosine followed by a saline push. For solving this question, I want to bring to your attention all questions of PSVT will be having three possibilities. What I mean by BP crashing is BP less than 90/60, equal to or less than 90/60. Just take care of the mathematical values here. If the BP is given to be more than 90/60, then the answer will change. And third aspect is prevention. For all questions of PSVT, if it is going to be hypotension and the blood pressure of the patient is crashing, then it is straight away a synchronous DC shock that would be used for management of this patient. If the patient is hemodynamically stable, we first go for vagal stimulation, after which we go for adenosine, that is chemical cardioversion. If adenosine fails, then we go for electrical cardioversion in a patient, and the saline push thing is valid. But for prevention, it is going to be catheter ablation, which is best. Otherwise, we can be using verapamil on a regular basis to take care of this issue. So the main answer in this case is no, doctor, just check it out. The discussion that I've had for prevention, even in rapid revision, is the fact that we will be going ahead with catheter ablation in our case. The correct answer for this is the sequence. This is the main summary that you need to remember for questions of PSVT. The question was regarding the prevention pass. वो ओल्ड आंसर्स ना ताविश, दैट इज ओल्ड गाइडलाइंस, दैट 350 वाला ना, अभी तो पीसीपी के लिए तो इट इज 200 ना, हैरिसन का जो रेफरेंस है दैट इज 200. Yeah, not given in asthmatics because it can trigger bronchospasm. So, yep. Okay, moving ahead, which is not a feature or triad of autoimmune polyendocrine syndrome type 1. Here my request is कि अभी मेन syndrome पूछ पूछ के ना बोर हो गया. तो अभी my request to you guys is everybody sitting for NEET PG. If you're sitting for FMG exam, कोई दिक्कत नहीं है, टॉपिक छोड़ देना, कोई फर्क नहीं पड़ता. But if you're sitting for NEET PG, मेन syndrome तो important है ही है. But because मेन syndrome has come so many times and they study in pathology, they study in medicine also. So he has stopped asking regarding MEN syndrome, and what you need to focus in that particular case would be autoimmune polyendocrine syndrome type 1 and type 2. Even in the PDF, this would be present. Yeah, chai time is a very good input that you have given there. That's a mnemonic that I'm describing. So ये जो table है इसकी आप चाहो तो अभी चाहे snapshot ले लेना while I'm describing it. Just take a snapshot of this table for autoimmune polyendocrine syndrome type 1 and type 2, because there are certain things that are common and there are certain things that are different. Like you can notice that type 1 diabetes is mentioned top up in the priority for autoimmune polyendocrine syndrome type 2, but not present in the top parameters with respect to patients who are suffering from Addison disease, autoimmune polyendocrine syndrome type 1, where there is Addison disease, hypoparathyroidism, and hypogonadism. And along with this, additional feature that is always asked for this condition is mucocutaneous candidiasis. So one, if you can just click a picture of it, it would, I think this has to be like a memory in your mind with respect to the involvements that are seen in this condition, because they'll make it all except question. And yes, vitiligo and associations are more common with autoimmune polyendocrine syndrome type 2. So he says which of the following is not included in the triad. So it is mucocutaneous candidiasis, then can be hypoparathyroidism and Addison disease in a patient. I mean, mainly present in the triad would be the manifestations that are discussed here. And therefore the correct answer for this particular question would be given as option number C. Which is not a feature that is going to be seen in autoimmune polyendocrine syndrome type 1 and in the triad, then the answer would be given as diabetes mellitus. Chai time is the mnemonic that I currently mentioned before you at the moment. So you can just focus on that. Fine. I think most guys got it immediately. The correct answer is C. Yes, triad would not include onset. No, triad would be what are the manifestations of the disease. So manifestations are mucocutaneous candidiasis, then is hypoparathyroidism. So it is just that associations that have to be remembered. Okay. So we have this 30-year-old lady. She was admitted due to polytrauma, and then the question says on day 3 of admission, she's suffering from this breathing difficulty. And the blood pressure of the patient is 100 by 80 millimeters of mercury. So the question is saying like, what is the first test to be done in this particular case? There is a case of polytrauma, there's a breathing difficulty, the saturation is falling, and then the vitals of the patient are mentioning hypotension, not very significant, but yeah, cause of concern. The person is suffering from probably acquired deep vein thrombosis, and this deep vein thrombosis would have resulted in pulmonary embolism in a patient. How do I know it is a cardiac event? Because there is widespread second heart sound, loud S1 given in this question. So the first test to be done in this patient is to demonstrate that the person is having hypercoagulability, and therefore we will be doing is a D-dimer assay. The correct answer for this question would be given as option number B. Abhishek, type 1 is present in type 1. As you can see in the table, it is a component which is present, but it is not a part of the triad. No, the triad part would be having the initial 3 things only present. Okay, so let me explain this. Why not D? First test to be done in any patient of pulmonary thromboembolism is a D-dimer assay. This is the screening test to be done. Then is the investigational choice. The investigational choice is CTPA, CT pulmonary angiography. Then the next test which is to be done in this patient is to demonstrate that there is clots in the legs of the patient. That is a Doppler. That is to find the etiology. Most questions on this particular topic will revolve around these 3 points only. That would be D-dimer SA, CTPA, and pulmonary embolism. And if there's a hypotension, it indicates that it probably goes in favor of a massive pulmonary embolism in a patient. The correct answer for this one would be option number B, D-dimer SA, to demonstrate the hypercoagulable state. And this is not a case of fat embolism, as I mentioned. How to rule out air embolism in this case? Air embolism is seen in those patients where there's a center line in place, or it is seen after neurosurgery. So this is not a case of VAE, venous air embolism. For venous air embolism, either the risk factor will be neurosurgery, or the question will mention that the patient had a center line in place, not given air. And why this is not fat embolism syndrome is that the GERD criteria are not getting satisfied. There is no CNS manifestation described in this question. There is no petechia that are given in a patient. There are no petechia that are described. So that is why like fat embolism has been ruled out. And Wells criteria, no, not exactly, absolutely not. It is just simple. You don't need to get into those criteria for diagnosis of this case. It is just to understand that how the disease process is evaluating. So keep things simple for you and try to calculate those parameters. Most of the time they will not be given. Like he'll not begin by saying cancer surgery, hospitalization for these many days. Most of the time even vitals will not be given in a question. Like he'll not mention heart rate and blood pressure values. So if you go by the parameters, a lot of time they are not given. Yeah, petechia and confusion are not given in this question. Exactly. The answer for this is option number B. Why not ABG as a initial test? That's the algorithm, guys. सुन लो ना एक बार उसको रैपिड रिवीजन में जो मैंने डिस्कस किया है पल्मरी एम्बोलिज्म का, उसकी सीक्वेंस ये बताइए कि सबसे पहले डी डाइमर ऐसे करते हैं भाई. हाउ डू यू डेमोन्स्ट्रेट? मैंने आई हैव गिवन दैट एग्जांपल ऑफ द टेनिस प्लेयर सेरेना विलियम्स. शी इज आफ्टर अ डिलीवरी, शी इज complaining of leg pain, and then the D dimer assay was shown to be elevated. Then they did a CT angiography in this patient. So the answer in that case would be option number B. Okay, so this is the question that was coming up, that what do you do to differentiate acute kidney injury from chronic kidney disease? Every time you talk about chronic kidney disease, one, we check for the grade. Like the grade would be mentioned from G1 to G5. And apart from the grade, we also mention the severity of albuminuria. It is not serum albumin that will help in differentiation. It is albumin in the urine that will help in differentiation. So one, I want to clarify that if in FMG exam, the question was which test will not help in differentiation, it is gonna be serum albumin. But what will help in differentiation is albumin in the urine of the patient. So the differentiation is on the basis of creatinine दोनों में ही बढ़ेगा, and then urine output दोनों में कम होगा, तो ये दोनों तो बाहर हो जाते हैं. तो only thing that is left is size of the kidney and urine albumin. Now size of the kidney can be normal. The basic point is size of the kidney can be normal in patients of diabetic nephropathy. One of the leading causes of a person having chronic kidney disease is diabetic nephropathy, and kidney size can be normal in diabetic nephropathy. So it's not always that you will get shrunken kidneys. Now the thought process is every case of chronic kidney disease will be having a shrinkage in the size of the kidney. But in number one cause of CKD, the majority of patients, the ultrasound will show normal size kidneys in a patient. Yes, that is what I'm saying. Now, size of kidneys can be normal in diabetic nephropathy. I'll give one more example for this. I'll give you one more reason for this. HIV associated nephropathy will have damage to the kidney. Agreed? No? HIV associated nephropathy causes focal segmental glomerulosclerosis. So it will cause damage to the kidney. It will cause CKD manifestations in a patient. But you get enlarged kidneys in this patient. So I've given you two examples where in a person, the size of the kidney can be normal or enlarged, and still the person is having chronic kidney disease. In diabetic nephropathy, kidney is damaged. Still the kidney size is normal. And in HIV associated nephropathy, there are enlarged kidneys patient. I'll give a third example. All of you are aware of autosomal dominant polycystic kidney disease. In autosomal dominant polycystic kidney disease, ADPKD, you would again be having is enlarged kidneys in a patient. So what I'm trying to say is that ultrasound can show reduced kidney in CKD. It can show normal size kidney in CKD. It can show enlarged kidneys in CKD. So if you are having among the top three causes of chronic kidney disease, if you can be having shrunken like in chronic glomerulonephritis, enlarged like in ADPKD, and a normal in diabetic nephropathy, then ultrasound cannot be a discriminating factor. The size cannot be a differentiating factor. Yes, Tavish, the answer for that would be urine albuminuria. The earliest indicator of diabetic nephropathy is always albumin in the urine, right? That is UPCR, urinary protein creatinine ratio, that is always to be remembered. I'll just put a marker to this. For diabetic nephropathy, the test that you are supposed to do is UACR, that is urinary albumin creatinine ratio, is a screening test. It is not serum creatinine because creatinine will take some time to rise. By the time 50% of the kidney is damaged, that is when creatinine will rise. But if you want early identification of diabetic nephropathy, it is UACR, that is urinary albumin creatinine ratio. यूरिन आउटपुट तो दोनों में कम हो जाएगा ना, एक्यूट किडनी इंजरी में भी यूरिन कम आता है और सीकेडी में भी कम आता है. सो डिफरेंशिएशन इज बेस्ड नॉट ऑन द अमाउंट ऑफ यूरिन और ऑन द सीरम क्रिएटिनिन वैल्यू, इट इज ईदर द साइज ऑफ द एल्ब्यूमिन, इट इज द क्लासिफिकेशन which is to be answered. Okay. Then is which of the following is not a cause of hagma? This is like bread and butter question for you guys. High anion gap metabolic acidosis, not a cause of it. There's a mnemonic by the name of Dr. Fuse that I've told, and cult mnemonic. So from that you can solve this question. The answer for this would be option number A, that is renal tubular acidosis, and option number D, pyruvate decarboxylase deficiency, is an inborn error of metabolism, which again has metabolic acidosis present. This is the table, and this is again I think a repeat question on NEET PG that I have discussed, and time immemorial the same options are repeated in various permutation combinations, like in last time's NEET PG, like they incorporated inborn errors of metabolism. Like if they would have written organic acidemia, you would have told now organic acidemia you can still figure out, but then pyruvate decarboxylase deficiency will produce this abnormal metabolites, and those abnormal metabolites will add up to the anion gap. I mean, in all inborn errors of metabolism, IEM, abnormal metabolites will be added to the system, and they will contribute to a increase in the total anion gap mathematical value. So cult mnemonic and then Dr. Fuse and mud piles, if you're okay with this, is perfectly fine to get this question correct. The answer is option number A. Okay, next is a question on vasculitis, that is with respect to Behçet's disease. One of the tests that we do in this case is we use a hypodermic needle and we make a prick in the forearm of the patient, and it can result in development of a sterile nodule. So pathology test is done for this patient. Then one of the very important things I want you to remember is that cobblestone mucosa. Cobblestone mucosa is what we read on cobblestone mucosa is what we read with respect to imaging of the GI tract in patients of Crohn's disease. Similar type of manifestations can be seen even in Behçet's disease. So do take care of the fact, though I know because it's a repeat you're getting it correct, but just like you were comfortable that cobblestone mucosa is seen with Crohn's disease, the same kind of manifestation in the intestine with skip lesions can be seen in Behçet's disease as well. Why I'm highlighting that is because in Behçet's disease, mainly we focus on that oro-oculogenital manifestations. I agree to the fact that you know this component oro-oculogenital syndrome is the name for Behçet's disease, and we tend to focus on like the aphthous ulcers and the ocular manifestation of pus in the anterior chamber of the eye and the genital issues. But even the GI is involved in this condition of vasculitis and can cause issues. Now, B is a correct statement. Intestinal manifestations of cobblestone mucosa can be seen in these patients, but then the genital ulcers in these patients would be present not on the penis. The ulcers are present on the scrotum and they're not present on the dorsum of the penis. I mean, ulcers on the dorsum of the penis would be seen in a sexually transmitted disorder and not Behçet's. The highlight of this condition is, and we don't read about scrotal ulcers anywhere else. So I think that is what he was trying to check out, that are you aware that there's a vasculitis that can cause a scrotal ulcer? And then if you look at D, this condition can also be associated with vasculitis. No, vasculitis can involve the veins also. So because of the vasculitis component, there is a high risk of thrombosis, and even deep vein thrombosis can be occurring in these patients. So option number A, B and D are the okay statements. The wrong thing in this question is option number C, which is well picked up by you. That would be C. And you guys comment why do you have death in Behçet's disease? Cause of death in Behçet's. Blood vessel that can rupture in this condition and can contribute to death. Yes, quick answers please. I mean, patient of Behçet's disease or Silk Road disease, what would contribute to death in these patients? Yes. The usual cause of death in this particular patients. Okay. The cause of death in this patient would be a pulmonary artery hemorrhage. I mean, it would not be a pulmonary artery hypertension, but the vasculitis in this patient can result in a hemoptysis, and that can cause a pulmonary artery hemorrhage. I mean, normally we read about pulmonary artery hypertension, but here it's like a rupture of the pulmonary artery that can cause pulmonary artery hemorrhage and a hemoptysis. Exactly, pulmonary artery aneurysm can occur. And yes, a very important thing that came up in the question is that patients of Behçet's disease are predisposed to venous stroke. Venous stroke is where you read about that empty delta sign, cerebral venous thrombosis. CVT, cerebral vein thrombosis. Patients of Behçet's disease, this would be a woman, and she would be having predisposition to cerebral venous thrombosis. This is a venous stroke where we have is a good prognosis. Uh, Normally, like arterial stroke will always be having is a bad prognosis, but this is a good one, empty delta sign, and we manage the patient with heparin, enoxaparin for venous stroke. Yes, that's the point to be remembered, venous stroke in these patients. Absolutely, the correct answer in this, because normally in STDs, what we will notice is that there will always be a manifestation that is very, very classical, that is scrotal ulcer. So that is what they basically want to ask you for the paper. The eye manifestation is usually anterior uveitis. Like somebody mentioned the posterior component, yes, but it is mainly the anterior uveitis that is occurring, and that will cause that pus in the anterior chamber of the eye, and that pus in the anterior chamber of the eyes is the issues there. Okay. Yeah, painful and non-scarring ulcers, no? Painful and non-scarring ulcers. Okay. Any ulcer will be painful, no? I'll just write it down. Okay, moving to the next question. A young woman comes with difficulty in swallowing and the skin tightening of fingers. I mean, the key word in the question would be that skin tightening of the fingers, that is sclerodactyly. And then there's a Raynaud's phenomenon that is also described in this question. And he says face shows telangiectasia. So he's mentioned regarding Crush syndrome. Everything in this question is talking out loud about Crush syndrome. And the moment you say Crush syndrome, you know that there would be anti-centromere antibodies that would be present. So this was easy peasy one that you have picked up very rightly. The answer for this question would be option number C. Okay. Another interesting one, a hypertensive patient has come with muscle weakness and low potassium. ARR values are elevated. What is best to differentiate primary from secondary hyperaldosteronism? 24-hour urinary free cortisol is for Cushing, so that is ruled out. Dexamethasone suppression is also for Cushing, so it is ruled out. Yes, guys, quick comments there. How do you differentiate? First and foremost is primary would mean that there would be a adenoma. And in this case, there would be a bilateral adrenal hyperplasia. So imaging can help you in differentiation. No, imaging can help you in differentiation. So the first thing that would be done would be a CT scan in a patient. CT scan can help you in identification of whether the tumor is like it's a adrenal adenoma that is present. And bilateral adrenal hyperplasia, there would be a uniform enlargement of both the glands along with aldosterone renin ratio, because renin will be absent in adrenal adenoma case. So answer would be option number A. As far as option number C is concerned, adrenal venous sampling, that is useful for lateralization. I mean, you want to pick up like the person is having the tumor on which particular side, the left side or the right side. If it is very small, no, the CT scan may not give you very conclusive reports. But adrenal vein sampling we use mainly used for lateralization, that is to find from which side the tumor is coming. Like if the lateralization is specifically focusing on, I mean, there are mathematical ratios, I'll not get into them, but the point is aldosterone renin ratio and CT scan would basically help in differentiation primary versus secondary, because adenoma is usually gonna be a unilateral adenoma on one particular side, and BAH is like a hyperplasia. The imaging part can differentiation along with renin values also, because renin values would be extremely low because here feedback mechanism will operate now. So the ARR will be like super elevated, like values going up to 30. That means like the denominator is very less. Aldosterone is obviously super high because the tumor is producing, and the renin values would be tremendously low because of the feedback mechanism. And ARR ratios can be normal in bilateral adrenal hyperplasia. Why? Because aldosterone will be more and even renin will also be more. In bilateral adrenal hyperplasia, renin is more, that is why aldosterone is more. But in adenoma, there will be a feedback contributing to, I'll just write it here. If it is a adenoma, with respect to adenoma, you will notice that the values of aldosterone will be super high because it's obviously an autonomous tumor, and thereby by feedback, the renin values in the patient will substantially become lesser, substantially become red. But if it is a bilateral adrenal hyperplasia in a patient, then aldosterone is also more, and renin values are also more. So that also contributes to helping in differentiation, apart from obviously the imaging size. Yeah, Lidl is perfectly fine. I mean, the Lidl will be having is a totally different ballgame, because there it's a channel which is to be picked up. But at the moment, the correct answer for this question is option number A, but fairly interesting one, because we had even adrenal vena sampling given. But as I said, it is for the next step. Okay. Then is, yeah, it could be incidentaloma, no? Ruskin bond, that question that you're putting up, no? It can be incidentaloma also. We have to rule it out by doing endocrine based tests. Okay, which of the following is incorrect about a Guillain-Barré syndrome? So, IVIG is the first line treatment in this condition. Cytoimmunological dissociation is present. The diagnostic criteria that we're talking about here is Brighton criteria. And there has to be presence of areflexia also. So FAME is a mnemonic that we use for that. Flaccid paraplegia, then is flaccid weakness, areflexia, albuminocytological dissociation, monophasic course, and electrodiagnostic studies. But plasmapheresis is not done. It is like initially we go ahead with IVIG, and if required we can go with plasmapheresis. Both have equal efficacy. I mean, this statement itself is fundamentally wrong. It's not that plasmapheresis is not done in refractory GBS. The statement is fundamentally wrong, because he says that any of the two can be done for this particular case. The answer in this question would be option number D. And as far as the criteria are concerned, I'll just mention this once again. There is a flaccid weakness, because it is lower motor neuron type, demyelination most of the time, or axonal damage, so they can be areflexia. And then there is albuminocytological dissociation that is present in the FAME mnemonic of A. M would be for the monophasic course, and E would be for the electrodiagnostic studies. In this case, the electrodiagnostic studies are going to be like the nerve conduction velocity onwards. Okay. Then EGFR grade 3. I mean, this was a very peculiar question that came in last time's EDS is electrodiagnostics. Electrodiagnostics would be nerve conduction velocity. E is electrodiagnostic, and that would be nerve conduction velocity. EDX is electrodiagnostics, nerve conduction velocity, showing a decreased latency. Yeah, so you just need to remember, I mean, in the table only, they will mainly ask you this. Either they will ask you A, or they will be asking you regarding G3B. I'm seeing that people are making mistake there and are getting confused between G3A and G3B values. So rest is understandable. It is ये 30-30 का decrease है ना, 90 में से 30 गया तो 60 to 89 हो गया. लेकिन अभी जो reduction हो रहा है, that is 15 points. You can see it's a 15 point reduction that I've highlighted. If you got this correct, cool. But if you had any answer that went wrong here, just practice this. This is a very easy and a scoring question that happened. And the correct answer in this particular case, because it is asked G3A, would be 45 to 59. That would be option number B. It is G3A, that is 45 to 59. Yeah, just practicing them would make it easier for you. If you have any इसको practice कर लेना यार लिख के, that is a very scoring question. 30, 15, 15, and then a decrease that you can see. And now we don't use the word end stage renal disease, as you are aware. Now we don't use the word end stage renal disease, we use the word kidney failure. Moving to the next one, which is the first investigation recommended for diagnosis of pheochromocytoma. Quick answers please. Pheo present in a patient, and we're doing a first investigation. Yes. We'll be doing is okay. First investigation recommended for these patients would be urinary total metanephrine, guys. The answer is not D. Urinary mandelic acid VMA levels are used for diagnosis of neuroblastoma and not for diagnosis of pheochromocytoma. If both are given in the options, as I've mentioned, it is urinary total metanephrines which would be answered. Please take care of this fact that urinary veneal mandelic acid levels are not diagnostic. This has been asked in the NESET exam also, and that is why I thought I should bring this to your notice. That I agree that in Robbins and in pathology they talk about VMA, but the table in Harrison does not mention anything with respect to veneal mandelic acid. It is only total metanephrine and plasma metanephrine that are present. So answer in this particular case would be first investigation. No, first investigation. That is why urinary, and then is the investigational choice. This is screening. And this is then in endocrine, the only game is just write down the screening and the investigational choice. In fact, for every medical condition, first thing you're supposed to do is always write down screening and then write down the investigational choice, and your PT is sorted out for it. And yeah, it is SPECT, which is better answer would be dotatate PET CT scan for imaging. I'll just write it here. Imaging modality. If it is asked for any pancreatic neuroendocrine tumor, like it is insulinoma, glucagonoma, somatostatinoma, to name a few, or if he says what is the imaging modality for pheochromocytoma, in all of them, your answer would be given as, that is what they want to hear, gallium-68 dotatate PET CT scan is always the imaging modality of choice for pancreatic neuroendocrine tumors and PET CT as well. And yeah, I mean, the pheochromocytoma to pheochromocytoma hi rahega na, so it doesn't matter whether it's an FMG exam or a NEET PG exam. Okay. Next is a patient with cerebral toxoplasmosis who's admitted for treatment, and the laboratory is showing the sodium values to be low and potassium values to be normal. I mean, potassium is 3.5 to 5.5, so that is fairly decent. Plasma free, yeah, it is plasma free metanephrine and urinary fractionated values. Exactly. Aishwarya, you're right for that word, but here he's not even getting into that, no, free or fractionated values, because patient is having dangerous hyponatremia. So dangerous hyponatremia will contribute to possibly a risk of seizure in this patient. So confusion, disorientation, and risk of seizure would be present. I mean, hyponatremia will not cause a bounding pulse, so that is against this. Option A looks pretty decent. That is hyponatremia. There can be increased thirst in a patient because he has lost water from the body also. But then because it is dangerous hyponatremia, so I'll give more credibility to option number C as compared to that of option number A. And then distended neck veins, I mean, that is a feature that is given in heart failure. So B and D were ruled out. It is between A and C only. And yes, somebody pointed out very rightly, this is SIADH. Anytime they give you a CNS illness, cerebral toxoplasmosis, tubercular meningitis, viral encephalitis, pyogenic meningitis, all CNS conditions contribute to this. So anytime there is any CNS infection, always think in terms of SIADH causing euvolemic hyponatremia. Then they will ask you a bacterial pneumonia that will cause SIADH, that is Legionella pneumophila. And third would be lung cancer, that is oat cell cancer, or it can be carcinoid tumor, that is a ectopic production that is occurring in a patient. These are the three common scenarios that would be present. Why in SIADH there is a hypotension? The reason for that is there is loss of water now. I mean, SIADH, okay, there is an expansion of the plasma volume in a patient. Yes. So the hypotension would be not present in the patient. Yes. Okay. Okay. Answer for this particular question, yeah, that mnemonic, if you want to use that, is okay. Otherwise, confusion, headache, and risk of seizures for dangerous hyponatremia is what is to be remembered. Orthostatic hypotension is what you get mainly with patients who are having diabetes insipidus. Okay, so you are assisting in a thoracocentesis. Carcinoid also produces Cushing, is right. You are assisting in thoracocentesis for massive unilateral hydrothorax. And what would be done in the patient so that you can prevent this complication? I'll address this query that you mentioned just in few seconds after I'm done with this question. Option number A is insert the needle along the lower border of the upper rib. That will cause trauma. It will not prevent trauma. It will cause trauma to the neurovascular bundle. I'm writing NVB, that is neurovascular bundle. That is the intercostal artery, intercostal vein, and then the intercostal nerve can be injured. It will cause trauma. Perform procedure with patient in prone position. What we do is we make the patient sit up. So it is like patient is in a sitting up position and we stand behind the back and advance the needle when patient is breathing in. So the lungs will expand. That will increase the risk of pneumothorax. We should always do the procedure ultrasound guided, and when the needle is being inserted, we'll ask the patient to breathe out. We'll say breathe out, and that is when you insert the needle, because if you are like, you ask him to take a deep breath and the lung is expanding, there is a high risk of pneumothorax risk that would be occurring. But to minimize the risk of re-expansion pulmonary edema, we have to limit the fluid removal to less than 1.5 liters. So minimize the risk of re-expansion pulmonary edema. This is the reason why correct answer to this particular question is option number D. Okay. If you remove more than 1.5 liters of fluid, it causes the re-expansion pulmonary edema. Okay, we have this 45-year-old alcoholic cirrhosis patient. He's admitted with the Malena episodes, and he says what intervention will be done to prevent a GI bleeding risk in this particular guy. The question is regarding the prevention part and not for the treatment part. So he says like, what will you do to prevent the complication, because alcoholic cirrhosis is having a melena episode. That means that he could be having is a bleed, probably a upper J bleed that is a slow one at the moment, and that could be resulting in development of a melena. Okay, so quick answers here. Salt diet, that is for management, no? That is for current management. It is not for prevention. The question is regarding the prevention part. To prevent the GA bleeding risk, because ultimately all of these patients will be developing is esophageal varices. I mean, what you get in all of these patients is that there would be a development of esophageal varices. To take care of these endophageal varices, what we do is endoscopic variceal ligation. I think this was an easy question that should have been answered very correctly, but I'll just quickly address these questions of portal hypertension that will come. If he says, what do you do to prevent the bleeding risk in a patient? Your first answer is EVL, that is endoscopic variceal ligation. And if this is not in the options, then you will prescribe nadolol to the patient. If he says patient has already started bleeding and there is a crashing of blood pressure of a patient, and he says, what will you do in a patient? Your first answer will be that you'll put a wide bore cannula and give massive blood transfusion. And then you will start the patient on the drug of choice, that is octreotide. And then you will go for treatment of choice, that is endoscopic variceal ligation. Here also 3 questions have been discussed. One is, what is the first line treatment? What is the drug of choice for bleeding varices? What is the treatment of choice of bleeding varices? This is a quick summary that I've mentioned for the management here. Yeah, we can use terlipressin also. It is just that terlipressin can be given as bolus and octreotide would be given in the form of an infusion. Yes, when to go ahead with TIPS. Then TIPS is usually a transjugular intrahepatic portosystemic shunting. It is done for patients who are having refractory ascites, or if in spite of all this there is still a bleed present, that is when TIPS would be done. Transjugular intrahepatic is mainly for those patients where we are having refractory ascites, and you have already done paracentesis in a patient also. I mean, refractory recurrent ascites is where transjugular intrahepatic portosystemic shunting would make sense in a patient. Okay, or if there's a recurrence of a bleed in spite of all the procedures that I've done. Moving to the next question, patient is admitted with complaints of vomiting and diarrhea. The potassium is 3.2. That's the cause of concern in this particular case. And he says that what will not be a feature of this electrolytemia. So quick answers, guys. Hypokalemia can predispose to arrhythmias because it can cause a QT prolongation, and this QT prolongation can increase the risk of ventricular tachycardia. So A makes sense. Because the weakness in the muscles, there would be quadriplegia that can be occurring. So even B makes sense. Quadriplegia will be present. Na bache, quadriplegia will occur in a patient because hypokalemia contributes to muscle weakness in a patient. Now we're left with diabetes insipidus and a cerebral edema component. So let's have answers here. Quick voting, please. Yes. The correct answer is D, cerebral edema. Cerebral edema is seen with hyponatremia. Now, why diabetes insipidus? So listen to this. Hypokalemia has been shown to decrease the responsiveness. It decreases the responsiveness of V2 receptors. Hypokalemia decreases the responsiveness of the V2 receptors to antidiuretic hormone. That explains why the manifestations can be akin to that of nephrogenic diabetes insipidus. I'll repeat my statement again. Hypokalemia decreases the responsiveness of the V2 receptor to antidiuretic hormone. And if that will happen in a patient, then this is going to contribute to nephrogenic diabetes insipidus. And that's why like polyuria can be even present in this patient. But then option number D is mainly due to sodium fluctuation, which is where the answer will be option number C. QT prolongation can result, both QT shortening and QT prolongation both can contribute to development of this ventricular tachycardia. Next, what you can see is a water bottle heart in a patient. There's a lot of fluid outside the heart, as you can see. The cardiothoracic ratio is pretty distorted. There is a viral infection that had occurred in a patient. So this could have been pericarditis, viral pericarditis. And this viral pericarditis is then contributing to pericardial effusion. And because of this pericardial effusion, if the amount is very high, it can result in tamponade also. So pulsus paradoxus can be seen in this patient, understandable. We might have to do a pericardiocentesis and RA-RB collapse can be required. Last time NEET PG, there was one question in which RB collapse was not written. Only the patient's MCQ was saying RA collapse. But even that is sufficient for you to say that this is cardiac tamponade, because first we have atrial collapse and then we have a ventricular collapse, because atrial is a low pressure circuit. So even if you read a question that says echo shows right atrial collapse, I repeat my statement, echo shows right atrial collapse. If given in a question, you still have to think in terms of of a cardiac tamponade developing in a patient, but here it would not be a loudest one, it would be muffled heart sounds present. You know all about Beck's triad. So the answer is mainly focusing on Beck's triad component. Even if you don't remember all this, Beck's triad has muffled heart sounds, so you would not have a loudest one here. That would be the answer here. Okay. चलिए जी, which of the following findings will be seen in toxocariasis? Toxocariasis that I'm talking about is toxocaracanis. And this toxocaracanis is one of the causes for development of visceral larva migrans. So one, you read about toxocaracanis being responsible in microbiology for visceral larva migrans, and to date has reached the eye of the patient. So it says what finding will be present in this case. So your answer would be given as chronic endophthalmitis. Headlight in fog appearance is a feature that you see with toxoplasma. So it is ruled out. Cottage cheese and tomato ketchup has again been asked in an immunocompromised truck driver with a CD4 count of less than 50. That would be a pizza pie retinopathy and cytomegalovirus retinitis. And then option number D, candle wax stripping is a feature that is seen with sarcoidosis that can be causing is involvement of posterior uveitis as well. So it is a chronic endophthalmitis, which would be given in the answer in this particular case. So read it as toxoplasma in a hurry. Okay, okay. अच्छा, toxocariasis को toxoplasma पढ़ लिया. हाँ यार, ये भी I understand. I mean that again can be like, you see, our brain is good that you raised this point, doctor, that our brain can be sometimes playing funny games on us, that we read toxocariasis as toxoplasmosis. So a point well taken. I did not anticipate that, but yep, I mean you said a very valid point. Okay. तो चलता है यार, होता है लाइक वी मेक मिस्टेक्स, बट चलता है, वो सबके साथ होगा, वन और टू क्वेश्चंस विल ऑलवेज गो लाइक दिस रॉन्ग फॉर एनीबडी, सो डोंट गेट बॉदर्ड बाय इट, बट या आई मीन दैट टेल्स अस दैट वी हैव टू बी एट द टॉप मोस्ट level of our performance. Okay, then toxocaracanis is the dog roundworm. It is the dog roundworm and it causes visceral larva migrans. And then you are also aware of dog tapeworm, that is Echinococcus granulosus, where we get that water lily appearance with respect to the hydrated cyst of the liver and the lungs. And one more thing that I just want to mention here is that if albendazole is not working, we go for PAIR, that is percutaneous aspiration, injection of hypertonic agent like 20% saline, and then reaspiration for management of these patients. And maximum करने बच्चे, maximum attempt करने हैं. You have to I mean hit 190 plus वाला circuit को hit करना है. So you have to take a chance, it has to take a chance. And then is cutaneous larva migrans or creeping eruption, which is gonna be Encyclostoma brasileiense. That is normally we have Encyclostoma duodenale, which will be the traditional human hookworm, but it is the animal hookworm that is coming in, so it's causing a cutaneous larva migrans. Yeah, Garby classification used there. And then is larva currens, which travels very fast, that is Strongyloides stercoralis. So a bit of parasitology questions also coming in between, though the question was on the dog roundworm. And do take care of the word roundworm and the dog tapeworm, because it's the roundworm which is mentioned, and the dog tapeworm, the perspective would change and they would be a hepatomegaly developing due to hydrated cyst of liver and lungs respectively. Max करने हैं बच्चे मेरे हिसाब से तो. Then is the question in which a patient is having a pterygium, and there would be a line which is not very much visible to naked eye. We might be requiring a slit lamp for examination, but anyway the theory part is clear. Stocker's line would be having is deposition of iron. So answer in this question would be option number A, and rest are the dummy choices: copper, cobalt and molybdenum. It's mainly iron as a pigment that gets deposited. So answer to 141 will be option number A. Additional event is image-based question for Art's line that is seen with respect to trachoma. Though trachoma has been eradicated from a country last year in 2024, but then still, like, this sequelae kind of manifestations can be given for Art's line. Then they ask about obviously that KF ring that you are able to pick up. And apart from the Kessler-Fleischer ring or the KF ring, they can ask about Fleischer ring. That Fleischer ring is what you see with respect to person who's having keratoconus. In fact, two findings in keratoconus can be present. One of the findings that you see this white thing in the middle of the cornea, which are like those scattered white creases that are present. Those are what are called as Vogel's striae. So I'll just write it separately. Like this image, the white lesions in a keratoconus patient that is present is Vogel's striae.
And this in turn should not be mixed up with these horizontal, you can see the horizontal lines which are present in a buophthalmos, and these horizontal lines in buophthalmos are what are called as Habs. He will also mention ox size, or he will mention the word like the cornea of the patient is significantly enlarged. So Habs are those horizontal lines that can be seen with buophthalmos, Vogel's and keratoconus. In fact, two findings of keratoconus are mentioned here: the Fleischer ring and then the Vogel's. And KF ring is anyway for Wilson's disease primarily. Then color would be brown for all of them. I mean, that is what I wanted to bring to your attention. Even like KF ring will be golden brown only. So just a quick recap of the things that you're already are aware of. And yeah, one more thing, you guys can tell me which basal ganglia is involved in Wilson disease quickly. Which basal ganglia is involved in patients with Wilson disease? Yes, it is the lentiform nucleus. Very good. Can you quickly comment on the investigation of choice? KF ring is Wilson, and it is the lenticular nucleus which will always be affected. Can you tell me the investigation of choice for diagnosis of Wilson disease? Has been asked in last time's NEET PG, so I thought I should just include it here. Yeah, biopsy. Biopsy of the liver with estimation of the hepatic copper content is the investigation of choice which should be given. This is what Harrison says. Actually, what we should be doing in this patient is a PCR or a gene sequencing for PCR for ATP7B gene. But then because of the fact that in Harrison he has not talked much about the gene fact, so we'll go by the biopsy as an answer. And in the initial screening test, we'll be doing two things: serum ceruloplasmin and 24-hour urinary copper. So for the screening, I think it's never a challenge. I mean, that is easy peasy part that you need to remember regarding the ceruloplasmin values. But if this is not given, then your answer is 24-hour urinary copper. Both of these questions have come once in screening, no ceruloplasmin, so 24-hour urinary copper. Investigation, it is a liver biopsy that is to be answered. Yeah, early diagnosis, no. So if there is no cirrhosis and the coagulogram is okay, still better. Otherwise, we can give vitamin K and stabilize the prothrombin time, then do a biopsy, or we can give FFP and then stabilize the prothrombin time and then do a biopsy in the patient. Okay, fine. So this girl, she went to swimming with the contact lens on, and then she's having this radial keratoneuritis. That's the key feature of acanthamoeba. Yes, he's asking about acanthamoeba keratitis, and he's saying that what is the best management of this particular case. So we might have to do penetrating keratoplasty if the medical treatment will fail. But initially, like in any case, we'll do a medical treatment. So polyhexamethylene bigonide eye drops are used for management of this patient. The correct answer for this patient would be option number D. Penetrating keratoplasty is like a backup that would be used in case this radial keratoneuritis causing condition. The radial keratoneuritis can be seen here. If this is not responding to medical treatment, that is when penetrating keratoplasty would be done. So PHMB is the treatment, right? Correct comments there. And riboflavin eye drops is what we use lots of time in patients of keratoconus. Okay, yeah. Riboflavin eye drops would be primarily used for keratoconus. Yes. MRI, the imaging modality of choice. No, doctor, that is updated now. If you check out the rapid revision, I've explained that in the Hindi section also. I've updated that and said that it is gallium dotatate PET CT scan is the main investigation to be done. Okay, best investigation for best disease. I mean, look at the vocabulary. Best disease would be, I mean, this is affecting the macula in the patient. It looks like a egg yolk appearance that you can see. And the main problem in this patient is that the macula of the patient is getting affected. There are two investigations. One is ERG and EOG. The ERG is done to check for the problem with rods and cones and bipolar cells. But this is the disease of the retinal pigmentary epithelium. So what we do in this patient is the electrooculography, and the highlight in this patient would be an Arden ratio. I mean, normally we always have is a dark adaptation to light adaptation, and the value is more than 1.8 because it, like when we go from dark to light, we have is a light adaptation that is happening. The value is more than 1.8. Here the value is less than 1.5. That is a Arden ratio that is usually given for electrooculography. The correct answer in this case is option number C. And you can also see that if he gives you a graph, then as compared to a normal individual, you can notice that the light adaptation in this particular patient is substantially reduced. Like you get a curve which would show a increase in or upward swing in the reflection. Here this is not happening, so that highlights that Arden ratio that I was saying. And the correct answer for this question would be option number C. Best test for best disease would be answered by you primarily as electrooculography. Yes, vitally formed macular dystrophy is the case in this case. The central vision or the sharpness of vision would be affected, and there would be like a yellow leucofuscin material below the retinal pigmentary epithelium that looks like an egg yolk. Okay, so this one would be a pretty easy one. Aeroplane splint. Aeroplane splint would be useful for evaluation of. Yes, hit the comment button, guys. I think this is an easy one. The aeroplane splint, this would be for brachial plexus injury in a patient. So usually like they can give you image-based questions for various splints that would be used for nerve injury. So just try to make them here in a single diagram. Like you are aware of a cock-up splint that is used for radial nerve. Aeroplane is anyway clear. Then is knuckle bender for claw hand deformity, and Thomas splint is anyway like the legendary thing for a hip joint injury. So these are like the important splints, the names of which are already highlighted. It's just a orientation to the names that will matter. Okay. Okay, so what is correct about the fracture which is shown here? Don't focus on the image currently shown, like don't focus on this image, just focus on the X-ray which is shown, and you can see the radial styloid fracture is occurring. And the radial styloid fracture would be called as Chauffer's fracture. The answer for this question would be given as option number A. Great, perfect. I think everybody got it right. And then they will ask about Colles and comparison with Smith's fracture. So Colles has an alphabet O present here, so that makes it easier for you to remember that this would be an outward fracture that is occurring. And when it comes to Smith's fracture, it would be having an alphabet I here, so it would be an inward fracture. The only thing is it looks pretty easy at the moment, but then they use words like dorsal, anterior, and posterior, which can result in little of errors of a little bit of errors in judgment as well. So to prevent from that from happening, like you can use mnemonics, or if you are cool with it, you can remember it from theory also. So like our mothers always when we were young to tell us brush your teeth at night, so do Colgate post dinner. So what I mean is that here in Colles fracture it would be a dorsal angulation that would be happening, and then is I mean the dinner part is the dinner fork deformity that I'm talking about. Like the dinner fork is kept upside down, that's why the dinner fork deformity would be present. And when it comes to Smith's fracture, then you can notice that this would be a anterior displacement that is happening. So one, you just need to pick up in the image based question as well, the dorsal displacement that is occurring, the ventral displacement that is occurring, or the anterior displacement, and the deformities that is occurring in this condition is also different. One would be a dinner fork, and the second one would be garden spade. So just a orientation to be remembered. And yes, MBBS life, you said the right thing. Draw a line from radius to the thumb, and you can see the dorsal and the ventral deviation that is present. If it's outward, then it goes in favor of Colles. If it is inward, then it is Smith's fracture. Okay, so we are sorted for three fractures here. We left with Bennett's fracture. Bennett's fracture would be वो fist fight में ना कि जैसे punch मारा तो punch के time पे अंगूठे वाली side पे लगी, like closed fist punches are being exchanged between two people. So there's an impact on the wall. So usually in a fist fight, like there could be a fracture at the base of the first metacarpal. That would be a Bennett's fracture, as you can see in the current image as well. So like 4 fractures is what we have discussed in brief. Okay, then is the elderly woman. I think that's a standard question that they always give. Postmenopausal woman, she falls down in the washroom, and there can be two questions like this. Either she will go into subdural hemorrhage. I mean, every time they make an elderly woman fall down, either the question is on like subdural hemorrhage or the chronic variety where they present after 3 weeks, or it's gonna be this characteristic dinner fork deformity that is coming up. That would be I mean, the diagnosis is very clear, that is Colles fracture. And in Colles fracture, the nerve that can be involved would mainly be the median nerve. So the correct answer for this would be option number B. In fact, because they put up these questions of FOOS, that is fallen outstretched hand, I'm just giving you a quick summary here as well. If they give a question on a child and they mention pain at the elbow, then it would be supracondylar fracture of the humerus. At this, the query of a lot of people is, why can't it be a radial head dislocation? Then radial head dislocation will not cause any pain. I mean, the child will have limitation in movement, but it will not cause any pain, and there would be no deformity present. And with this fall in the outstretched hand, the nerve that usually gets involved in the patient is the anterior interosseous nerve in a patient. So we are trying to make the patient do a okay sign here, and you can notice that unlike a normal person, you can notice a very characteristic flexion. That is, I mean, when we do a okay sign in this case, that flexion would be missing on this particular side. So that would be anterior interosseous nerve getting involved. If it's an elderly or a postmenopausal woman and she's having this deformity, that's a Colles fracture in a median nerve. And then if it's like a young guy falls in sports on the outstretched hand, it would be a scaphoid fracture. In scaphoid fracture, quickly comment which segment will be developing avascular necrosis. Will it be the distal segment or the proximal segment? Yes, guys, which segment would be undergoing a avascular necrosis? Yeah, the proximal segment is the one, because the blood supply of the scaphoid bone is retrograde, so it is the proximal segment that will undergo a avascular necrosis. So most of the time, like the fall and the outstretched hand questions are fairly easy to pick up, and I think you've done a great job by picking them up. We have this guy who's diving headlong into a shallow pool, like Sirke Balgira. Recently, also I saw a video, on scrolling through, like, all of us keep on scrolling on social media. So sometimes your feed is like showing accidents only. And this year has been crazy for accidents. So I saw this video where a guy jumped into, I think he was jumping into a swimming pool only. And, or I think there was one girl who jumped in a mall, in that area where you can do trampoline, etc. And she immediately ended up with a quadriplegia. So what can happen in these patients is that there can be a burst fracture involving the C1 vertebra, as you can see in the image in this particular case. So very good, very good. Do not use Instagram. And the answer for this would be option number A, that is a Jefferson fracture. Hangman fracture would be mainly involving the C2 component, and this would be usually like hanging or road traffic accidents. Then Gray-Schobler would be with respect to the tip of the, this is the spinous process of the vertebra. So it is the spinous process of the vertebra that will be affected. And this would be seen in mainly construction workers, like he's shoveling clay, that is the stress on the neck can contribute to it. And then is the odontoid fracture for, again, I mean, injuries, but not very classical for diving injury. I mean, every time we talk about a diving injury, then burst fracture of the C1 vertebra is Jefferson that I'm describing at the moment. The correct answer in this question is option number A, and I think everybody could pick this up. So these were like those questions which would be helping you up in identifying that the person could be, I mean, if the patient is not managed well, they could be inflammatory damage to the spinal cord as well. Okay. Next is regarding what is correct about the image that is shown, especially if the mobilization of the patient is not done properly and the patient is being shifted to a hospital. That is where these kind of manifestations can occur. Yes. So the answer in this case is dequervain tenosynovitis, and this is like the patient is having a severe amount of pain when you ask him to simply do a or like a medial shift of the wrist joint, and this is a dequervain tenosynovitis. I'll just show images for the remaining three facts, which are like you can see one is dequervain tenosynovitis, then is Phelan sign, and then is Froment sign, which is being done subsequently to evaluate regarding ulnar nerve palsy in a patient. Like the three aspects which are being talked about here would be Phelan, flexing the wrist together for 60 seconds, and then would be Froment sign for the ulnar nerve. I mean, you ask this guy to hold a credit card or any other piece of paper between the fingers, and you can notice that the guy is having that flexion of the thumb IP joint, indicating a adductor pollicis weakness. Then you would have seen Pope, no? Pope, whenever he's giving, like, like in our religion, like any Panditji, when they give Ashirvad, they do give it with full hand. And Pope, then they're giving like, it's more like hand is would be like this, that is like a hand of benediction. And that hand of benediction occurs in a median nerve injury. So answer for this particular question is anyway sorted. But then because they put up these images, so I thought I should rather describe with images instead of focusing on just the theory component. Okay, so I think you can solve this question by just reading the theory only. There is recurrent episodes of vertigo, and there is a tinnitus and a fluctuating hearing loss. I mean, that's the keyword, fluctuating hearing loss. That makes it easy. Otherwise, you can notice that at low frequencies, there is a problem, and there's an upsloping curve that is one occurring. So one, I think even your ENT teacher tells you about that upsloping curve, and mainly it is the low frequencies which are getting affected here. So the combination of this low frequency sensory neural hearing loss, and along with that upsloping curve. The answer in this case would be given as Meniere's disease. The answer for this is option number, yeah, rising curve, like Presbycusis says older age group, so it shows a declining trend. That's what we learned traditionally, and Meniere's will be having upsloping. And another feature is Meniere's disease would be having mainly the damage initially will be in the apex, and apex of the cochlea is where the pressure will be more high, so low frequencies are affected. At the apex of the cochlea, the low frequencies are the ones which are heard by us, and in the periphery of the cornea, it's the high frequencies that are heard. So it's the low frequency hearing loss that is occurring in this case in endolymphatic hydrops. So the answer for this question would be option number C. And then it's that classical question, because they'll show you two dips only. Either the dip will be seen at 2000 or at 4000 hertz. And here you can notice the dip occurring at 2000. And that is what is called as a Cahart's notch. And the moment you pick up that 2000 dip at Cahart's notch, you know that you're talking about otosclerosis. And in a case of otosclerosis, we'll be going ahead with the stapedectomy. So pretty straightforward there for interpretation. And there is a airborne gap also present, because this would be conductive hearing loss. But then along with the conductive hearing loss, there is a bone conduction also getting affected, because stapes is getting affected. So ultimately, like, stapes is going to conduct, so it gives that pseudo finding of bone conduction being affected. Okay. Okay, moving to the next one, we have this lady. She is in the third trimester of her pregnancy, and she's having multiple episodes of syncope in last 1 week. And the question says, her blood pressure is 110 on sitting and decreases in supine position. I mean, that's the peculiar thing. Normally, like, blood pressure tends to decrease in, like, when the person will stand. And here, when she's sitting or she's standing, the BP is okay. But when she's lying, then the BP is relatively low. So what is happening in this case is that there is compression of the IVC. I mean, what is happening is that when she's lying in supine position, the gravid uterus is causing compression of the IVC. The venous return of the patient is becoming lesser, so that is why the blood pressure is decreasing in a supine position, and that explains we need to tell this lady to turn to one particular side, especially while lying. And then everything else in the question is a distraction, because hemoglobin is 10 and the serum ferritin levels are low in this patient. So for this patient, we will give iron deficient, we will give like iron supplementation, but not parenteral iron in this patient. I mean, hemoglobin is 10, so I don't need to give like parenteral iron in this patient. And there is no cardiac issues. It is just a compression of the IVC, iotovenal compression, that is occurring in this case. So the correct answer is restricted physical activity and rest in lateral position for management of this case. So answer is option number B. Yeah, supine hypotension syndrome is the best way to describe it, because traditionally, like in medicine, we deal with people who are having like orthostatic hypotension. But here it is ulta. When the patient is sitting up or standing, BP is better, because the pressure on the gravid uterus on the IVC will be lesser. But in supine, due to gravity, the IVC gets compressed, which is why this supine hypotension syndrome would be occurring in the patient. Okay, so this is sorted, guys. Pretty easy one, I would say. Let's move to the next one. What color of the escaping liquor would alert you to the possibility requirement of urgent cesarean section? Most of the time we go do it for fetal distress, and I think that is good enough a hint, because meconium, the first stool of the baby, will always be greenish in color. Normally the baby passes stool after birth, and that would be usually in the first 48 hours. Most babies pass it in the first 24 hours only. So I mean, more than 90% babies pass meconium in the first 24 hours. But if there's a fetal distress occurring in a patient, that would mean that the anal sphincter of the patient will relax and there would be defecation. And because of this defecation, the meconium will get fixed with the liquor, and therefore a meconium stained liquor can be present. So it would be like a yellowish greenish appearance that would be present. So the answer in this case would be option number B. Dark brown is for intrauterine death. Golden is for RH incompatibility. Yes, golden is for RH, and saffron is most of the time very subjective. But yeah, most of the time the books mention it for like post maturity. So the answer in this case is option number B, that is green discoloration liquor would indicate that there is a fetal distress. Urine is 48 hours, guys, and feces, I mean, XYZ, I think you asked from pediatrics domain. So urine can be passed up to 48 hours, but stool should be passed in the first 24 hours. Okay. Then differentiation of cyto and syncytial trophoblast occurs on which day following The fertilization, I mean, the syncytial trophoblast is the one that will be secreting the HCG, and the differentiation would be occurring on. Quick, hit the comment button, guys. These are easy ones and easy peasy ones that you need to answer. The answer would be option number B, that is day 7 here. Again, a fact-based question that has to be remembered. And syncytial trophoblast, it would secrete HCG as well. Then which of the following is correct about Nitabuch layer? I actually put up this question because in last time NEET PG there was an image-based question on placenta accreta, I mean the placenta sticking to the uterine wall, and the reason why that placenta accreta would be coming up is mainly because of the absence of this particular layer. You see this Nitabuch layer, is basically responsible. The Nitabuch layer is mainly responsible for limitation the penetration of the I mean the placental into the uterine wall, and if this is missing, it then results in development of this manifestation of placenta accreta. The correct answer for this is option number A. Off-pair cells are for security anyway, so answer is A. Nitabuch layer absence causes placenta accreta. And then there can be terms like increta and percreta also. So if it's more deeper, then it called be percreta means it goes through the uterine wall. If it goes deep inside, then it is increta. Otherwise, just adherent is the accreta component. So three terminologies: accreta, increta, and percreta. Percreta means it goes through the uterine wall itself. Okay. Then is Leopold grip. Second one is used to assess for the images is what I've already shown before you. So we have is the first maneuver, the fundal palpation, that will let you know whether the buttocks are there or whether it is the breech presentation or whether it is a cephalic presentation. And then in the second Leopold grip, when you are evaluating, you are checking for the back of the patient and whether you can feel the hands. That would be the position of the shoulder. So the correct answer in this case would be option number C here. That is the position of the anterior shoulder is the one that would be picked up here. So, and the third one is called as pollic grip. That again helps you know that there is gonna be engagement that would be occurring subsequently. And pollic grip is, I mean, this anyway, you have already known that whether it is a cephalic or a vertex presentation, but pollic would let you know about the transverse lie part and the engagement part as well, because if the part has not gone down into the pelvis, then we'll say the head is non-engaged. Exactly. So this is a simple table which you are already aware of. So I don't need to teach you all this. You are familiar with this. But yeah, at our time, we had nobody teaching us. We had to go through Datta, and these images are like, you know, that standard Datta images come back to flash as a flashback to the memory. Okay, the head is ballotable. Yes, that's the term if it is non-engaged, and if it is like going down in the pelvis, then it would be non-ballotable. Okay, which is correct about molding? Quick answers, please. Let's look at your responses in this case. I'm getting C as an answer, bache. That is gonna be caput succedaneum. That is stagnation of fluid in the scalp before the girdle of contact is caput. So that is ruled out. Molding is a normal phenomenon which will occur due to friction between the maternal pelvis and the baby's head, and there will be overriding of the sutures, and that will help in facilitation of the baby from going out. So answer in this question is option number B. And no, it's not a feature of cephalopelvic disproportion. Agreed that it will be more pronounced in cephalopelvic disproportion, but it will not change the bimastoid diameter. It is the biparietal diameter. I mean, what is changing in this case is the biparietal diameter, and if the biparietal diameter becomes lesser, then the head of the baby is relatively deformed in a fashion that it can come out of the birth canal. I'll just show a diagrammatic representation here. Molding does not cross the suture line. By it is overriding of the sutures. You know that swelling where we say cephal, when we say crossing the suture line, this is a feature that you see for the bleed. You know, when you are talking about like cephalohematoma versus caput succedaneum, like caput succedaneum is gonna be like a boggy swelling in the whole scalp of the patient in cephalohematoma. So when you're comparing cephalohematoma versus caput, that is when you talk about like crossing the suture line or not. But at the moment, we are not talking about like a bleeding versus a caput. It is like a molding which is overriding the sutures that would be seen with the babies coming out of the birth passage. So the correct answer in this case would be option number B. Yes, it is BPD, biparietal diameter. Then is true about diagonal conjugate. So this diagram has to be remembered. This is symphysis pubis. And from the symphysis pubis bone only, you are doing a paravaginal examination. So if it is going to be from the upper part of the upper part to the sacral promontory, that's the bone mark that we're talking about, then it is called as true conjugate. But obviously, like when you're doing a pervaginal examination, then the distal end of your index finger would be touching the lower part of the pubic bone, so that would be what is called a DC, that is a direct conjugate. So one is a TC, true conjugate, obstetric conjugate, and a diagonal conjugate. The obstetric is coming from the middle of the pubic bone posteriorly present. So there are three terminologies that I'm bringing to your attention, and here we're talking about the lower border of the symphysis pubis to the midpoint of the sacral promontory. The answer for this would be option number B. Yeah, TOD is the term to be remembered. Perfectly spot on said there. TOD right from top to bottom. Then is biophysical scoring. We use it to assess for fetal hypoxia or acidosis. And the mnemonic for this is breathing efforts, then amniotic fluid index, tone, movements of the baby, and then is acceleration by a non-stress test. So we do not take into consideration a fetal scalp pH in this particular case. And then there's a modified biophysical scoring as well, in which only two parameters are present, that is amniotic fluid index and a fetal heart rate. So if they say biophysical scoring, then there are like more parameters present. That would be 1, 2, 3, 4, 5. And if it is modified, then you will say only two parameters to be taken into consideration. The answer for this would be option number D. Okay, mechanism of labor in a cephalic presentation. Quick comments there, and I hope that you are not checking out from the app. Hit the comment button, guys. Okay. Okay, so let me just show you a reference from Datta so that there are no issues there. Like what you have is initially engagement and increasing flexion, but then you have is an internal rotation of the occiput. So ICD is how we used to remember it. Then is the crowning, then is the delivery of the head, and then we have is a restitution and external rotation. So it is like internal rotation, then crowning, then delivery of the head, restitution, external rotation. So it is ICDR, then is restitution, then is external rotation. So with that, if you look at it, crowning, that is okay, all of them. Delivery of the head by extension, okay, so that is okay. And then is restitution and external rotation, okay. Okay, fine. So correct answer in this case would be option number A. Option number B is saying delivery of the head by extension, so that is anyway ruled out. It is crowning, delivery of the head by extension, then restitution and external rotations. Perfectly spot on. Then is active management, a third stage of labor. So we have is an expectant management and we have is an active management. Expectant is like due to gravity only, the placenta will be expelled out. And I just gave this image to show that, you know, recently there was this Russian woman, she was living in a cave, and she delivered a baby by herself. So I mean there it would have been expectant management only, that the placenta would have come out by the gravity aspect only. But in active management, we'll be giving oxytocin or mystardine injection with the delivery of the anterior shoulder of the baby. Then we ligate the cord, and then we remove the placenta using a controlled cord traction. All of you would have taken on delivery. So we do a controlled cord traction and we gradually remove the placenta. So here the correct answer would be, he's saying what is not correct about the active management. So we don't wait for spontaneous expulsion. That would be done for the expectant management and not in the active management. The answer is C. Then is a long stem question on primigravida. The question mentions that this lady is having a 6-week amenorrhea with pain in the lower abdomen, with vomiting and prostration. And now you can notice that she is going into hemodynamic compromise. I mean, this is a long-term question. There's a tachycardia, there is a hypotension. Anytime you read a question on amenorrhea with a shock, you always have to think in terms of a ruptured ectopic pregnancy. And I mean, I'll repeat that statement. Anytime in a question of amenorrhea, there's a circulatory failure occurring, we have to think in terms of a ruptured ectopic. And there's a blanched vaginal mucosa because she's lost a lot of blood internally. And he says what is best to present the confirm the diagnosis. So we'll do a TVS in this particular case. A transvaginal scan would be done. I mean, obviously we will be doing blood grouping in this patient because cultocentesis is ruled out because that's a old way. Blood grouping would be done in this patient subsequently, but first we need to pick up that there is a ruptured ectopic happening in this patient. So for that, I mean, it could have been a one-liner only, but it became a little more pronounced question with circulatory failure. So we'll do a TVS and that will show that there's a ruptured ectopic occurring. Estimation serum beta HCG values. Yeah, I mean, I can do serum beta HCG sample in the patient, but then that would not be taking a priority over a TVS because we need to plan the treatment of this patient. Okay, blood in the cul-de-sac. Yes, why not HCG? That's what I'm saying, guys. You need to first diagnose the case. No, I mean, if a patient comes with circulatory failure, I need to first know what is going on, and then subsequently I can know whether if she's saying herself amenorrhea, she got recently married. So I'll take that she had uh, a pregnancy coming up, and then subsequently this unfortunate event occurred. Okay, so I think everybody could pick up that classical snowstorm appearance on a ultrasound, and this is indicative of the fact that there is a H mole which is present in this case. The beta HCG in this patient is gonna be super elevated. The main hint in this question is the passage of grape-like vesicles. I mean, every time you read about grape-like vesicles expand per vaginum, and then you don't hear a fetal heart sound. I mean, you know, the cervix is favorable, but there is no fetal heart sounds present. So that means that the products of conception are not there, and there's a snowstorm appearance. So what we need to do is a suction evacuation in this case. The answer would be option number A. Methotrexate would be answered in those circumstances where there is going to be like a gestational trophoblastic neoplasia. When we talk about like a GTN, then it is methotrexate, but at this moment it is a suction evacuation that would be done in this patient. Okay. Okay. Absence of any measurable amount of amniotic fluid sonographically would be called as, yeah, invasive mole. Yeah, that is GTN I was saying. Then is absence of any. So if there is oligohydramnios, that is less, we just have to use English in this question. No, but it's not A, it is B na, because it is saying absence. So absence में तो anhydramnios हो जाएगा. Yeah. If TVS will show presence of bleeding, no, transvaginal scan will tell us that there is a bleed component present, and then we can subsequently go for salpingectomy in this patient because the tube has burst in this patient. Okay. It is anhydramnios, guys. It is not oligohydramnios. I think I did get the feed as A as well. Now we have is a 24-year-old primigravida with hypertension. She's at 26 weeks. The BP is elevated, and there is no proteinuria that is given. So quick answers there. Yes. Since there is no target organ damage, the KFT in the serum uric acid is normal in this patient. So this is not pre-eclampsia. Pre-eclampsia should be having evidence of proteinuria. And in this case, because there is no evidence of proteinuria given, that is why the answer would be given as gestational hypertension. Nowadays, we don't use the word pregnancy-induced hypertension. It is mainly pre-eclampsia and gestational hypertension to be remembered. And if proteinuria is absent in a patient, end organ damage is present, end organ damage is absent, then we say it is gestational hypertension. Otherwise, it would be pre-eclampsia as an answer. So sorted. Okay, coming to 165 Pritchard regimen. They love to ask about this magnesium toxicity aspect. You will comment in the chat box answer of the question and the cause of death in magnesium toxicity. Do let me know why patient will die due to magnesium toxicity, and let me know the answer in this question as well. Which is not useful for determining magnesium toxicity. So reflexes will be affected in the patient, agreed. There would be respiratory depression, agreed, because magnesium is an antagonist of calcium. Calcium is for contraction. If contraction will not happen, the diaphragm of the patient will fail. ECG will show a bradycardia, and then there would be urine output. Normal urine output is 1 ml per kg per hour. For a 60 kg man, it would be 60 kg. And what you can check out here is that the urine output is showing 60 ml, so that is perfectly normal. So urine output of 60 ml will not be useful for diagnosis. In this case, the answer is option number D. And the cause of death in the patient is cardiac arrest or asystole. So there are two things that I've said. One is magnesium will be antagonist of calcium, so the heart will relax and asystole will occur. And in Pritchard regimen, what will not help you would be a urine output charting showing urine output of 60 ml. It is 30 ml or lesser that would be giving you an input. So urine output is not going to be helpful in this particular case. The answer is option number D. Okay, not correct about placenta previa. We talk about antepartum hemorrhage. Two varieties, placenta previa and abruptio placentae. And the most important thing would be, values, SRR you are mentioning. Okay. Urine output substantially low is indicative, no? But urine output of 60 ml per hour would not be indicative of any under perfusion of the kidneys. Okay. Okay, which of the following is not correct in this particular case of placenta previa? So height of the uterus is bigger. That would be a feature that is seen with abruptio, no? Because if it's a concealed hemorrhage, in abruptio placentae, if it's the concealed hemorrhage, then what's going to happen is that the height of the uterus will be disproportionately bigger and the uterus will also be tender to touch. So, I mean, that comparison of findings between abruptio placentae and a placenta previa is being discussed. The answer in this question is option number A. Rest is fine. I mean, fetal heart rate can be present in placenta previa. Not all placenta previas will contribute to, I mean, death of the fetus immediately. Head is high floating, engagement is not occurring. No, head is high floating because engagement is not occurring because the placenta is inserted in the lower segment of the uterus and the uterus would be soft. Yep, the correct answer in this case is option number A, and that there would be tender uterus present. Okay, incorrect about iron status in a pregnant lady. Yes, guys. Iron will be less, ferritin will be less. Yeah, TIBC is always going to go opposite of wherever the percentage saturation transferrin is going. So total iron binding capacity would be increased because of a compensatory system coming in. No, whenever in the body iron is less, then the intestinal binding capacity will tend to increase. The answer will be B. Okay, so WHO table of cardiac mortality with respect to pregnancy is what is being discussed in this question. Which condition will have the least risk of maternal mortality here? The question is not on the highest risk. I understand highest risk is with pulmonary artery hypertension and aortic stenosis, but at the moment the question is with respect to least risk of maternal mortality. Okay, so I'm having multiple inputs there. The least risk would be if she's having an artificial heart valve. No, if she's having a valvular lesion and if you treated it with an artificial valve, then she'll not have risk. Suppose she was having uncorrected aortic stenosis. Suppose she was having untreated mitral stenosis. Then it is the cause of a problem because the output from the heart would be less. But in this particular case, the bottom line is that bioprosthetic heart valve, if it is put, that means the heart valve was, the cardiac disease was treated. Na? So if we have treated a heart disease, then there is no obstruction to the exit of blood from the heart, neither inflow problem, neither outflow problem. So therefore the person would be doing fine in this particular case. So answer in this case would be option number D. One of the highest risks that we see is with pulmonary artery hypertension and Eisenmenger, right? I mean, one of the highest risks is seen with pulmonary artery hypertension and Eisenmenger, and then is like the aorta problems that would come, aortic root dilatation, for example, or aortic stenosis that would be coming. But in this particular case, it would be like a bioprosthetic heart valve where the treatment is given. Okay. Next case, we have this lady. She is a known case of GTCS. General anesthesia and delivery, we'll not use GA, no? We'll go for spinal anesthesia and do a cesarean section, no? Yeah, pulmonary artery hypertension, Eisenmenger. Marfan is right. Marfan is because of aortic root dilatation, as I said. Yep. Okay. Lady is on sodium valproate and she's already for 5 years on this medical treatment. So which of the following is gonna be unlikely to be seen in this patient? ओके, क्लेफ्ट लिप एनेंसेफेली तो न्यूरल ट्यूब डिफेक्ट्स तो होगा, सो न्यूरल ट्यूब डिफेक्ट्स का होने का रिस्क तो इंक्रीज है. And most of the time, these drugs can cause a vitamin K deficiency. Because of anti-epileptic drugs, vitamin K deficiency can be seen, so even neonatal hemorrhage can be seen. Now I'm left with a malformation and neonatal seizures in a patient. भाई neonatal hemorrhage का risk इसलिए है ना कि all anti-epileptic drugs can cause vitamin K deficiency. So I'm left between option number A and option number D. Then cleft lip and cleft palate. If a lady is on medicine, then teratogenicity will occur, no? Because all drugs are teratogenic. So they may not only cause a neural tube defect, but they might even cause a craniofacial dysmorphism. But अगर valproate बच्चे में जा रही है तो बच्चे को दौरे तो नहीं हो सकते ना. बच्चे के ब्लड में भी सोडियम valproate जा रही है तो उसको तो दौरे नहीं पड़ सकते ना. The answer is D. The reason for that is if the child is already on sodium valproate, if the child is already on sodium valproate, or like the child is getting literally the drug from the mother, no? So less chances of seizures in a child. The correct answer is D. So I would say bit of logic to be used in this question that neural tube defects will occur and any malformation can be seen in fact, and then is vitamin K deficiency, which is the way you are able to expel or you are able to rule out the options. Okay. We have this 28-year-old lady. She is having one baby. She's pregnant for the second time and she's having labor pain at 34 weeks for past 6 hours. So that's a preterm labor. And I mean, there is evidence of fetal distress coming up because the fetal heart rate is showing values consistently lesser. So in these circumstances, right, you can see that because she is going into a preterm labor, the bag of waters periodic uteral contraction is occurring in this patient. So that tells me that she's going into active labor. And he says like, what is not to be done in this case? So considering a preterm labor, I anticipate that her baby will be born preterm, hyaline membrane disease will be present. So giving betamethasone to the mother will decrease the risk of hyaline membrane disease. So makes sense. Left lateral position also okay, and blood transfusion fine, plan for urgent cesarean section, that makes sense. But then once the labor is already on its way and there is evidence of fetal distress already given in a question, then going in for tocolysis would not make sense. I mean, I don't want to stop the process that is already occurring in this case. The baby is unstable at the moment. So in the setting of fetal bradycardia, a non-reassuring cardiotocography, tocolysis is going to be contraindicated. The answer is C. This lady is having leakage per vaginum for previous 24 hours. 24 hours, right? So that's gonna cause an ascending bacterial infection. That is gonna be troublesome for her. So which complication can develop in the mother? If you are having a leakage per vaginum for a huge 24 hours at 32 weeks of gestation, the bag of waters has burst and she's come to the hospital late, then you can understand that there could be an ascending infection. That would be chorioamnionitis. The amniotic fluid itself will become infected, and the complication of this would be the baby will be born with pneumonia. So with chorioamnionitis, we can be having is the development of congenital. I mean, this will increase the chances of development of even congenital pneumonia. The answer for this would be option number C. Okay. Next is about a nulliparous woman. She's having anemia, irregular cycles, and there are multiple fibroids in the enlarged uterus. Yeah, no steroids would be given. Amniotic fluid embolism for this lady. Oh, amniotic fluid embolism will cause respiratory distress, no? I mean, if after delivery, if the question says that lady has just delivered after delivery, and there is a respiratory distress in a patient, respiratory distress in the mother, sudden onset, and there is no bleeding per vaginum, that is amniotic fluid embolism that is occurring. But here it is like leakage per vaginum only. So that would be congenital, chorioamnionitis that would occur. Yeah, delivery has to happen. That's a good way to say that delivery has to happen. Okay. The next question is on the topic of fibroids. The lady is having menorrhagia. There are multiple fibroids which are present, and he says all of the following are true about this condition except. Okay. The center of the fibroid, once the fibroid is present, the blood supply in the center of the fibroid is relatively lesser. That is why we always read about red degeneration of the fibroid. So option number A is a correct statement, because the blood supply comes from outside to inside. So the inside of this is having the least amount of blood supply, and that is why, because the blood supply in the fibroid is not from the inside to outside, it is from outside to inside. So we can get a red degeneration. Then cervical fibroids can kick the ureter. It is understandable if this is this is the uterus and this is the cervix. Then the problem is that adjacent to, if I just modify this a bit, if this is the cervix, then adjacent to this would be the ureter. So if we are having a fibroid here and it is increasing in size, it can press on the ureter and that can result in hydronephrosis in a patient. So kinking of the ureter can occur. Then this mifepristone is used to reduce the fibroid size. That makes sense because that would be progesterone based drug. But a subserosal pedunculated fibroid, you mean that a fibroid that is being present on the outside of the uterus, right? Subserosal, that cannot be diagnosed with a saline infusion sonography. I mean, saline infusion sonography can identify a fibroid which is present on the inside. Like if a fibroid is on the inside, on the side of the endometrial side, then it is okay. That a saline infusion sonography can help in identification. So it can help in submucosal fibroid detection, but not for a subserosal one. The subserosal one is what you can see here is present on the outside. So that can be picked up by routine ultrasound and not by a saline infusion sonography. So the correct answer for this question is option number D. If you ever look at this kind of an image, I mean, the uterus wall will be collapsed, no? Like the uteral wall collapse would be present. And then you can input in saline. You can put in a saline and you can check out the walls. And in this particular case, what is happening is that the fibroid is present on the outside. So a saline infusion sonography will not be useful in this particular case. Yes, subserosal pedunculated fibroids cannot be diagnosed on a saline infusion sonography because they're present on the outside is the way to answer this question. Answer is D. Okay, then serous cystadenoma of the ovary, where we read about Samoma bodies. So one was a easy pickup. And he's saying which of the following is not correct. Yes, keep hammering is the punchline, right? That's what we need to do. That's what we are doing, guys. It's almost been 2.5 hours that we've been doing this activity. So just you need to persist a little more. Just think it as like an exam. Give another 20-25 minutes to this, and you will be in a better frame of mind. Okay. Yes, there 40%, the rule of 40 is present here, bilateral 40% malignancy, but it is not the largest benign ovarian tumor. The largest benign ovarian tumor would be a mucinous cystadenoma. The question is on serous cystadenoma. The largest benign ovarian tumor is mucinous cystadenoma, which is why the answer for this particular question is option number D. Okay. So we are sorted for 173. Okay, 174, not a component of Meek syndrome. Somebody mentioned Meek in the comment also, so I could not pick it up there, but maybe this is what the question that you were mentioning. So Meek syndrome would be having no, bhai, this is not my merchandise. I got it. Okay, not a component of Meek syndrome is gonna be a right-sided pleural effusion that would be occurring in this case. It is not a left-sided pleural effusion. Question open to you guys. Why do you get a right-sided pleural effusion, by the way, in Meek syndrome? I mean, we understand there is a ovarian tumor, Brenner's tumor of the ovary is present, so it will irritate the pleura, and irritation of the irritation of the peritoneum will explain the ascites. Why a hydrothorax? Why a hydrothorax? Irritation of the peritoneum will contribute to ascites in a patient. So understandable. We will get ascites in this case. Any ovarian tumor can contribute to ascites. Why a hydrothorax? Because the transdiaphragm spaces binding is connected to each other via transdiaphragmatic holes, and these holes are gonna be जो ट्रांसडिफ्रैक्टिक होल्स होते हैं वो राइट साइड पे ज्यादा कॉमन होते हैं एज कंपेयर टू द लेफ्ट साइड सो दैट्स व्हाई दैट्स द राइट साइडेड प्लूरल effusion that is mentioned here. So yeah, I mean peritoneal cavity and pleural cavity are in a communication, and that is why like we get a right sided pleural effusion, and here it is written left sided. Okay, then is pseudomyxoma peritonei manifestation. This would be like a mucinous gel in the peritoneal cavity. This is a tumor of the ovary that has burst and is contributing to this pseudomyxoma peritonei, the mucinous gel filling in the peritoneal cavity of the patient. This mucin word is the one which is to be picked up here. That would be a mucinous cystadenoma. Yep, answer is A. Good. Keep commenting in the chat buttons, guys. I mean, you need to. Okay, right and left. So transdiaphragmatic holes more on the right, so right-sided pleural effusion would be commonly seen. Okay. This 28-year-old lady, yeah, Brenner's auto. Okay, fine. That's a point that I take, but ultimately, like the pleural effusion part would be the discriminating factor. Okay. In this question, there is a dyspareunia, painful intercourse, infertility, and then is the keyword nodularity of the uterosacral ligaments, nodularity in the pouch of Douglas, and bluish spots on the posterior fornix of the vagina. That means there is some bleeding going on, right? Some endometrial tissue is present in the posterior fornix of the vagina, and this endometrial tissue can be present in the uterosacral ligaments and could be present even in the pouch of Douglas. So that tells me that this is a case of endometriosis. The correct answer for this question would be option number B. I mean, the main hint in the question is that bluish spots on the posterior fornix of vagina, which means bleeding, and endometriosis can then cause a chocolate cyst of the ovary. So there was an image-based question on the chocolate cyst of ovary in last time's paper. Two image-based questions was placenta accreta, and then was a question on this chocolate cyst of the ovary, and the clinical history was also given. So most guys were able to pick up not only on the basis of the histopathological specimen, but a similar sounding history was given in the question. Okay, then is HPV trial strategy would be involving obviously pap smear, so that is given in the options. The first test that we do is, yeah, powder burn lesions is another term for this. So pap smear is the first test to be done. The next one to be done is a PCR for hepatitis human papilloma virus DNA. And if this turns to be positive, then the next time to be done is a colposcopic directed biopsy. So this is the HPV triage strategy that is present. The answer for this question would be given as option number A. The steps are pap smear. If it is abnormal cytology, then it is like LSIL, low grade squamous intraepithelial lesion, DSIL or HSIL, high grade squamous intraepithelial lesion given, then HPV DNA PCR, and then it's gonna be colposcopy that would be done. Okay. Yes, LSIL basically means that low grade squamous intraepithelial lesions. That's just the common reports that you'll be seeing. Okay. We have this lady, he's asking Figo staging of carcinoma vulva, and there is inguinofemoral lymph nodes which are involved in this case, and involvement of the lower one third of the vagina. So you need to get practice the Figo staging. I mean, normally we study only with cervical cancer, but they have asked about vulval cancer, so that is why this is important. Mainly, it is the spread of the cancer to the lymph nodes and lower one third of the vagina, which is to be remembered. So if it is involving the vulva, if it is inguinofemoral lymph nodes that are involved, then we will call it stage 3. The correct answer in this would be option number C. And the staging is anyway mentioned here. You guys would have read it multiple times also. So why not option number B in 1177? Okay. Yeah, but then first test is to document the organism responsible, no? So HPV DNA is to be done first, guys. That's a standard protocol that is made, so we'll follow that only. Yes. Stay anytime in vulval cancer, if there is inguinofemoral lymph nodes, I mean, that's the main aspect to be remembered there. Tumor with inguinofemoral lymph node involvement is stage 3. Yes, 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 yes. VIA is a cost effective test. वो शायद FMG का क्वेश्चन था ना कि visual inspection with acetic acid is the cost effective test. That was like the FMG exam question that came. Okay, so we are sorted for the vulval cancer part, and then is regarding the spread of cervical cancer. He has mentioned cervical cancer. He said, what is the common route of spread of cervical cancer? Quick comments regarding how does it spread? Yes, and you can also comment in the chat box, what is the cause of death in cervical cancer? Yes, the answer would be C, that is direct local spread. Can you quickly comment in the chat box what would be contributing to the death in these patients? Usual cause of death in cervical cancer. You answered beautifully. Direct local spread. What would be the cause of death? Yeah, uremia, renal failure. Because direct local spread will kink the ureter, no? And the kinking of the ureter would then contribute to development of hydronephrosis. And this hydronephrosis would then contribute to uremia in a patient. So perfectly spot on. It would be renal failure that would contribute to death in these patients. Yes. Next is a cervical cancer that is infiltrating into the urethra of the patient and is contributing to hydronephrosis. So this line diagram basically makes it easier for you. The ureter would be present on the side, and this ureter is the one that is getting kicked in this particular case. So that would be stage 3. That would be again answered in this particular case. So we just have to get used to involvement of the upper one third of the vagina, upper two third of the vagina, and lower one third of the vagina. Those are two separate things that are usually written. So if it is gonna be like if we say upper two third of the vagina, then it is stage 2A. If it is lower one third of the vagina, it becomes a stage 3A. And for 3B, it is the ureter that is involved. I'll say that quickly again. Upper two third of the vagina involved, then it is stage 2A. If it is lower one third of the vagina getting involved, it is 3A. And 3B is when the ureter will get involved in the patient. And if it involves the rectum, then it is 4A in a patient. If rectum is involved, it is stage 4. This would be stage 3 cancer. All of the Figo stagings are to be practiced with the help of a diagram only. The diagram has to be very, very small and has to be very, very precise. Mainly from the Figo website or in your notes also, those diagrams would be given. Even if you don't go into like 2A and 2B and 3A and 3B, the gross first step is to get the gross jurisdiction right with respect to the stage of the cancers. Then is the stitch for cervical circlage operation. I mean, this lady was having recurrent abortions, and because of this, the recurrent cervical recurrent abortions that she was having due to cervical incompetence, we have put a stitch, but now it needs to be removed. So the best time of removal will be just before the baby is achieving the term value, that would be 37 weeks. So this would be at 36 weeks as the best answer. And when do you put it? Then it is at 12 to 14 weeks, because this is the important cause. Cervical incompetence is usually a cause of second trimester abortion. So if he says when do you put the elective circulage, it is 12 to 14 weeks. If he says when do you remove it, it is 36 weeks onwards. Yes, answer is C to this one. Risk of tubal pregnancy will be increased with which of the following? Malformations of the uterus will increase the risk of abortions, right? So the risk of tubal pregnancy would be highest with which of the following? Okay. No, malformations of uterus does not increase the risk of tubal pregnancy. I mean, malformations of the uterus can either result in infertility or it can increase the risk of abortion in a patient and not the risk of a tubal pregnancy. Tubal pregnancy can be seen in IUD because if IUD will usually prevent a pregnancy, but if pregnancy occurs with IUD, then it is a tubal pregnancy. The basic thing is IUD is basically put to prevent a pregnancy, but if pregnancy occurs with the IUD in situ, then it is gonna be IUD failure, which is responsible. I mean, then there is because the environment of the uterus will become non-favorable for the fertilized ovum because the environment of the uterus is not suitable for the implant fertilized ovum to get implanted. That is why the tubal pregnancy will occur. So the answer in this patient would be option number B. Okay, so one, you can notice that normally the placenta will always be having umbilical cord inserted in the middle. I mean, we always should be having umbilical cord in the middle, but in this case, you can see the umbilical cord is like having this leash of blood vessels and they're inserted in the margin of the placenta, very far away from the placenta. So what you see here is a velamentous placenta where you can notice a big leash of blood vessels, and this is usually associated with vasa previa as well. So V for velamentous placenta, and there could be blood loss from the fetal side. I mean, the blood of the baby will be lost. That is vasa previa, implies that it is the fetal blood loss that can be occurring. So that's again an important aspect to be remembered. Then is a placenta that looks like a tennis racket, but it is not having a leash of blood vessels going in the entire periphery, but it is just adjacent in the periphery. So that would be called as a battledore placenta. And then there are two lobes which are present here. I mean, you can see the lobes present here. So that would be called as a succenturian lobe. So the correct answer in this case is option number B, option number A. So velamentous, then battledore, and then succenturian lobe. Okay. Moving to the next one. We have this lady with a metallic prosthetic valve, and she's metallic prosthetic mitral valve. Okay, so I thought it's aortic. Metallic prosthetic mitral valve is planning to get married, and she's in your clinic because she's using an anticoagulant, and they want to start a pregnancy as soon as possible. Okay, so she's taking warfarin, right? And she wants to say that what would be the best advice for her to conceive subsequently. I mean, fetal warfarin syndrome would obviously be a big no. And if I discontinue warfarin, I'll not start with digoxin. So the correct answer in this case would be low molecular weight heparin. The answer in this case is option number A. I mean, the standard part is any patient on prosthetic valve, metallic valve would be put on oral anticoagulation with warfarin, mostly because of it is rheumatic etiology. So we have to make a shift here to prevent the chances of fetal warfarin syndrome. Okay, which of the following will not be seen in an infant born to a lady with gestational diabetes mellitus? Yes. Quick answers, please. If the lady is having gestational diabetes mellitus, then we can be having hypoglycemia. There would be a large baby hypocalcemia, but it will not be sacral agenesis, because for sacral agenesis, it should be a pre-existent diabetes that should be present in a patient. For sacral agenesis, the lady should be diabetic. It is not gestational diabetes, which will start later part of the pregnancy, that is after 20 weeks. It is pre-existent diabetes mellitus should be present. Only then would you be getting is a sacral agenesis or neural tube defects. The answer to this particular question would be option number D. So we have this lady, she's having anemia, and the second, and she's having macrocytosis also. The two things present, macrocytosis and anemia. He says, what is the next best step in management of these patients? She's in the second trimester. The diagnosis of this lady is a macrocytic anemia. Though ideally in this question, even the serum iron values should have been given, or at least the ferritin report should have been given. But considering the options in this particular case of macrocytic anemia, we will be putting this patient on folic acid and vitamin B12 for management of these patients. The answer would be option number C. So what you see here is a rocket endocervical bush for endocervical sampling. That will give you a better cytological yield. When we have a IR spatula also, the image of which I am showing on the slide before you, that's a IR spatula. And then subsequently what you can notice is a Carmen cannula. The answer to this question is option number B. Great. Keep the comments coming, guys. You're doing great. Then for nulli gravida, okay, quick comments again for this one. 188 nulli gravida would be, yeah, not pregnant now and never in the past. Nulli gravida. Answer would be option B here. Which method of prenatal diagnosis will be having the highest chances of a fetal loss? Because if we are doing any procedure which is invasive, there is a risk of development of damage to the fetus as well. So I mean, prenatal diagnosis, and answer cannot be culdocentesis, because culdocentesis is not a method of prenatal diagnosis. Culdocentesis is like when we want to identify what is present in the pouch of Douglas. So in this case, we are not doing a, I mean, A option is anyway ruled out because that's not for prenatal diagnosis. It is amniocentesis, chordocentesis, and then is going to be chorionic villi sampling. So the highest chances of fetal loss would be when you are doing the procedure late, because chorionic villi sampling is what is usually done between 9 to 11 weeks or max like 10 to 12 weeks. Amniocentesis would be 14 to 16, and when it comes to chordocentesis, it is mostly between 18 to 20 weeks. So if we are doing any procedure late, then there will be more chances of fetal loss in a patient. So therefore, the answer in this case would be given as option number C. The rationale in this particular case is only that any procedure that you are doing more later in the part of pregnancy will be having, because of more vascularity, there would be a possibility of this fetal loss occurring in a patient. The answer would be C. Yeah, it does not say least fetal loss, it said the highest fetal loss. No, that's why the answer is not chorionic villi sampling. With chorionic villi sampling, there can be like limb reduction defects that could be occurring. Okay, another question on placenta previa. Steroid therapy is given in which of the following? I mean, that word is expectant treatment versus active interference only. Yeah, in RH incompatibility, we want to make a Lilly's chart, no? We make a Lilly's chart and then decide the level of, we'll do a chordocentesis to check the baby's hemoglobin also, so that he needs an exchange transfusion or not. But then steroid therapy would be given in which of the following? Okay. I have reference for this from Datta only. Expectant treatment is when there is no active bleeding occurring in a case of placenta previa. But if it is gonna be bleeding is continuing, patient is at 37 weeks, then we anticipate that the delivery will occur before time. So the steroid therapy is given in this particular case. So it's an active interference that they mentioned this in the reference which is given here. Answer for this is B. I understand that expectant look makes sense because the patient is having no active internal bleeding, so it looks like okay, we should be giving steroids there. But the point is like, what is the need for giving steroids if she's not going into labor? The fetal heart rate is reassuring, the CTG is showing a reactive recording, then we don't anticipate a delivery occurring, no? So everything is fine, so no need of steroids. But if we know things are not good and not looking up, then we have to go in for giving steroids in this patient. The answer would be option number B for active interference. The reference from the book is very much given. Okay, MBBS life is a good answer there. Eat 5 star. Okay, all are correct about intrauterine devices. One question, contraception comes at the weird options, no? Okay, so intrauterine devices, all are correct except. Hit the comment button, guys. It's a reversible method, makes sense because of the blood loss. Because if you put a IUD device, it will cause increase heavy periods. There would be menorrhagia. So giving iron supplements in this patient also makes sense. IUD for 5 years, but it will not inhibit ovulation. No, it will just make the environment unfavorable for fertilization of the environment. The copper T380 Ag will inhibit the, or it will make the environment unfavorable for implantation. So it will not be inhibition of the ovulation part. The answer would be D. Okay, let's move to the next one. Few remaining ones here. Two about Ayushman Bharat program. So quick comments there. Yes, coverage of 5 lakhs per family member. So it is not per family member, it is per family, right? So I'm removing the word per, it's not member. Like we are not America that we can give 5 lakhs per member. So that is ruled out. And this is obviously like for everybody, it is universal, whether it is men or woman. So it does not matter. I mean, this is a wrong statement. A is a wrong statement. B is a wrong statement because universal. To be eligible, one member should be paying income tax. No, it is for poor people. I mean, that Ayushman Bharat scheme is basically made for social inclusivity, and that is based on socioeconomic caste census that has been done, SECC that has been done. I mean, the correct statement is excludes if they put on guidelines and checklists. Like if somebody in the rural India is owning this much biga of zameen, or if the guy is having a refrigerator, or he's bought a car, or he's bought a bike, then that guy is not having that socio-economic deprivation. That is I mean, that particular class which is having extreme socioeconomic deprivation is the one which should be given this program on a priority. So excludes if, yeah, that is the correct statement, no? Okay, that is, yeah, PM name will always be there. So he's saying what is the correct statement in this case? Excludes if the family owns a refrigerator. Lots of time in rural India ना, जैसे होता है कि कई लोगों के घर गांव में इतने बड़े बड़े मकान, मतलब क्या यार, वो मतलब कोठी जो होती है उनकी, वो ऐसे मतलब एकड़्स में फैली हुई होती है, राइट? एंड लॉट ऑफ पीपल लाइक अमिताभ बच्चन इज ऑल्सो फार्मर, नो? ऑल ऑफ these Bollywood actors, they're farmer, they don't pay income tax, and they have so much of zameen, right? And they don't pay any tax only. So I mean that basically they try to say socioeconomic deprivation means a guy person living in rural India, and if he's owning a refrigerator, we don't give him the facility. If he's not even having refrigerator, ghade se pani pee rahe, we give him the facility. So the answer for these patients are the correct one here. Yeah, I think auto activist, that is for all people more than 70 years of age. No, that part is coming up. Okay. Okay, fine. For evacuation of vaccine coverage, what is the best method? Yes, we will not go to like every house and say whether you have received the vaccine. We'll select some selective clusters, right? Like suppose in the area of South Delhi, in Gautam Nagar, they want to check out. So they'll pick up sector A, some houses in sector B, some in sector C, like that. And then they visit 30 houses in sector A, sector 30 houses in sector B, and then they'll try to find out. So what we do here is called as a cluster random sampling. That is option number C. Snowball sampling is always done whenever it's like a hard to reach group. Like if you want to do if you want to reach out to IV drug users, if you want to reach out to transgenders, then you have to be you do a snowball sampling. That is ensure that you connect with one of them, and then he will connect you to the rest of the community. But for this question, it was like 7 children, 30 clusters, perfectly fine. That would be 30 into 7 technique that we follow. So I can just write that also. And that would be for vaccine coverage. That's a WHO recommended technique. Okay, all of the following are quantitative continuous polyautomous variables, except I think you can solve that by mathematics only. Blood pressure can have any value, weight can have any value, platelet count can have any value, but blood group cannot be like any value. No, blood group has to be A, B, B, A, B, or O. So that's why the correct answer in this case would turn out to be option number C. Okay. Okay, last 5 to go. This is all except MCQ. He says disposal steps for wasted sharps would include all of the following except needles, right? What we're talking about is the biomedical waste disposal. Questions usually come on this. So which is not a component, right? Or which will not be used. Okay, so I'm getting all kind of answers there. Destruction with needle cutter is okay. Concrete pit is fine. Left pit and microwaving and incineration. Yes, we don't do incineration, guys. Incineration is not a part of wasted sharps part. No, if you look at the algorithm also, like we don't go for incineration. It is, yeah, I mean, I mean, that is one of the components that is given between two close options. I'm saying it's the incineration or the destruction of those sharps is not done. Okay. Answer is D, guys. It's not B. Microwaving makes sense. I mean, at least to make it non-infective, no? At least to kill the viruses which are present there, we can be doing microwaving, but incineration not done. Long stem one now. National, I mean, I hope that this decade we get rid of TB, because if we don't get rid of TB this time, no, if BPAM does not work, guys, then I don't think so. I mean, it's literally like losing the race against it. So, I mean, since I mean, decades, no, it's almost like 2 decades, and we've been reading about tuberculosis to be taken care of. So these 5 years, I think, are very, very crucial for our government to be very aggressive for management. Okay, so we don't use our 12-month regimen. I mean, that I can rule out immediately because it's saying which of the following of this particular conditions is accurate. So we don't use a 12-month program. And we have to go for a contact tracing. So that also makes I mean, contact tracing discouraged is the wrong thing. No, we have to find out the contacts of a person and trace them out. So two options are ruled out. Uh, we are being aggressive. Like initially we were saying that we'll do sputum microscopy and we'll do gene expert only in people living with HIV. But currently you will notice the fact that it is like gene expert is a diagnostic test that is done in all presumptive cases. So we are trying to be aggressive because that will help us even identify drug resistance immediately. So we know that, I mean, instead of giving ATT to a guy and then waiting for the drug resistance part to show up subsequently, it is better that we identify it immediately because gene expert would let us know the resistance to the initial two frontline drugs. So the answer for this question would be option number B. Okay, mathematics is not my forte, but you guys are gonna do this question on negative predictive value, NPV. Quickly comment on CB-NAT is the other word for it, or gene expert is the other name for it. Okay, negative predictive value. Yes. I think everybody could work this up for the true negatives part. Negative predictive value, it would be true negative and total positive people who tested negative in this particular report. So 730 by 750, I said my maths is bad, but usually it will go in 90s only. 750 into 10 would be 7500, right? So it would be something like 0.9 or higher. So the answer in this particular question would be option number D. And then just practice it out. The sensitivity, specificity, mentally try to calculate from this table for all the components that are mentioned: sensitivity, specificity, positive and negative predictive value. It's just a bit of practice that is required. And like I was morbidly afraid of these kind of questions in a sense that my mathematics was bad, so I used to end up with wrong answers. But you guys done a great job in this particular case. The answer would be 97%. Okay, correct about letharism is kesari dal, right? That is contribute, like we eat that chane ki dal, right? That's the kesari dal, which would be steeped in water overnight to prevent the toxins from going in. But in this case, that consumption of kesari dal will cause us spastic paralysis. And for this condition, we will be having is like a spastic weakness in the legs. Patient will have difficulty in walking. There is no edema of the legs. Edema of the legs is seen with Argemon mexicana poisoning. No, that mustard oil poisoning. जैसे we guys would be using Safola or other uh, uh, Safola or other good cooking oils for our consumption, but mustard oil contamination can result in development of heart failure manifestations in a patient with development of edema in both limbs in a patient. So that is mustard oil contamination, Argemon mexicana. Remaining things are okay, but letharism, the answer would be option number D. Yeah, epidemic dropsy is the correct statement there. For epidemic dropsy, it is edema of both the limbs. Okay. Then is eye strategy is used for which of the following infections? Easy one here. Quick answers, please. Parboiling and vitamin C for prevention. Yes. Yes, guys. I think everybody is aware that this is the elimination of yellow fever. The correct answer for this is not A. I think you should be aware that for trachoma it is safe. We discussed this one, even in the test series that we conduct regularly face to face. We discuss questions like these, and in that face to face session also we saw that most guys were answering this question only. So one of my colleagues had also shared this with me that eye strategy likha tha, so everybody is answering it as trachoma. So I thought I should just mention this here. Then it is gonna be yellow fever. Yeah, I am hungry. Yes, doctor, I'm hungry. So we just have one more question to go, and then we are done for today. Yes, it is option for this is eradication of yellow fever epidemics is what is recommended. The correct answer in this particular question would be option number C. Okay, very good, very good. Yeah, eradicate. I said that, man. I said that eradication of yellow fever epidemics. It is elimination of yellow fever epidemics is what is recommended. A very particular eradication, elimination. So elimination of yellow fever epidemics. Okay. Okay. JEET program is for tuberculosis, Anna. Joint. You guys can comment here. Who funds the JEET program? Yes, guys. Okay. So it is not WHO, state government, and these are like Okay, the fine answer would be given as global fund. And what will happen is when you give a test, then the chances of errors are more. And when you're listening to me, answers is less because then you're listening to me also, so the audio stimulus is coming. So just think like this. I'll be talking to you in your exam also, like mentally visualize, and I'm helping you with the right answer. The answer for this is option number D. And yes, guys, it was really fun to interact with you guys and revisit my previous medical school day years and relive them again with you. So thank you so much for your patience and joining with us. And I can say that you guys are doing great. We'll try to conduct some more sessions if they're required, but I think that we are hitting that ultimate level where there's too much of information floating on. And I think that you need to just utilize this 12 to 3 window. I think this is the most vulnerable period of the day for everybody. Like in ECG, no, middle of the T wave is the vulnerable period. कि टी वेव के मिडल में अगर पंच लग गया तो वेंट्रिकुलर फिब्रिलेशन होता है. ऐसे ही मैं देखता हूँ कि मॉर्निंग वाला जो आवर होता है ना, क्योंकि हम रात को पढ़ते हैं, so by the time we wake up at 12 and by 12 to 3 is the least productive period of the day. So we've done 100 MCQs and you guys can do much more than that. So I think in my opinion, if you productively utilize these hours into 3 slots of 3 hours each, just study 9 hours every way, just give 9 hours of every day to your study for the remaining days and you would be doing great. For FMG students, if you have listened to this, great. I mean, you're doing a great job because a lot of these questions are like, very logical and very easy ones, right? You need to get 150 marks only. And for NEET PG guys, I mean, I understand the competition is intense and everybody is getting the best kind of knowledge and information, but yeah, you will be able to persist. So if you get 3 slots of 9 hours each, I think that is more than sufficient. And if I was able to mentally exhaust you, then that is my job to do that. I mean, my job is not to make you laugh or entertain and crack jokes. So that's the easiest thing for anybody to do. But what we do is serious stuff. We get into that hardcore things and try to um, get you into that groove which is finally required for the exam. So see you subsequently, and thank you so much. Custom modules would be better, doctor, because I think yeah, I'll take care of the PDF, man, don't worry, the PDF part would be fine, right? But at this moment, yes, what matters is seeing you on the other side is perfectly okay. Yes, 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 yes. Sevoflurane, doctor, that pediatric surgery was sevoflurane only. I understand that desflurane issue is only one, that there is highly pungent and that's why it is gonna be not very suitable for pediatric anesthesia. Okay, fine guys. Take care. God bless you. It was really nice interacting with you and see you.